evening, everyone. Welcome to the 15th edition of Kalpavriksa. Kalpavriksa means wish fulfilling divine tree. So this was a national level CMA program which was started way back in 2007. This is our chairman and managing director, Dr. Amar's brainchild. He wanted to teach the postgraduates whatever best we could. So that's how it started. This is a 3-day program usually, and it is conducted for the benefits of the postgraduates. This time, this Kalpa 2022, we are doing it online because we want to give the benefit to all the people all over the world. So for 3 consecutive Saturdays, we are having this program. Last week, we dealt with cornea, cataract, and glaucoma. The speakers are handpicked and they are experts in their fields. And today we will be covering retina, oculoplasty, intraocular tumors, and neuro-ophthalmology. The first topic of the day is going to be diabetic retinopathy. Diabetic retinopathy was to be dealt by Dr. Preetham Samant, but unfortunately he was not able to join today. So he has asked his dear friend to help us with this, and he has gladly accepted it, and he has agreed to do the diabetic retinopathy instead of Dr. Preetham Samant. We welcome you, Dr. Hasanan Shikari. He's a retina specialist with a special interest in diabetic eye disease, age-related macular degeneration, and retinal vascular occlusive disorders. He is the director of ophthalmic care at Erith Clinic, Mumbai. He is an alumnus of Grand Medical College and Lakshmi Eye Institute and trained as a fellow for 3 years at Harvard Medical School, Boston. Dr. Shikari has authored numerous journal publications and textbook chapters and lectured at several national and international meetings. We welcome you, sir, to present today's topic, diabetic retinopathy.
Thank you, Dr. Sondri. It's a pleasure to be here. I'm glad to be standing in for Dr. Preetham, who unfortunately couldn't be here today. Let me begin by wishing everyone a very happy Diwali. So let's get into diabetic retinopathy. Now, diabetic retinopathy is it's a disease of the retina that's caused by microangiopathy due to a long-term effect of diabetes, leading to progressive damage of the retina and then consequently blindness if left untreated. This is the most common cause of severe bilateral visual loss in a working age group. So now what predisposes someone to getting diabetic retinopathy? The age of diagnosis of diabetes is very important. Younger patients have a longer duration of exposure to diabetes. Younger patients usually have more difficulty controlling diabetes. So this tends to cause some element of diabetic retinopathy later on in life. The duration of diabetes is very important. This associated with poor metabolic control, where the patients have hyperglycemia one day, they go hypoglycemic another. So basically, it's this gross fluctuation in blood sugar levels that can also predispose one to diabetic retinopathy. Pregnancy and pregnancy-induced diabetes predisposes patients ultimately to diabetic retinopathy as well. Associated systemic issues such as hypertension, nephropathy, smoking, obesity, hyperlipidemia, all of these are predisposed risk factors. Now, coming to pathophysiology, diabetic retinopathy is a microangiopathy, and hence bears similar roots to that of nephropathy. You will see a lot of patients being referred to you by a nephrologist to check if the patient has diabetic retinopathy, because it sort of cuts short their work. So here, this is a microangiopathy, primarily affecting the precapillary arterioles, capillaries, venules, and postcapillary venules. And the basic component of damaging process is microvascular occlusion and microvascular leakage. So what exactly happens? So in diabetes, because of the inflammation, there is basement membrane thickening, which leads to endothelial cell damage. This coupled with RBC changes, where there is a rouleau formation, the RBCs become more sticky, this platelet stickiness which is increased, leads to occlusion of the micro arterioles. On the venular side or the capillary side, there is a loss of pericytes. So this loss of pericytes leads to changes in the wall of the venules or the capillaries, leading to microaneurysms. If these microaneurysms burst, they can lead to hemorrhages, and microaneurysms, because of loss of pericytes, can also lead to leakage. So coming to the flow tree of the pathophysiology, there's capillary changes and there's hematological changes, which leads to microvascular occlusion. Following microvascular occlusion, there's retinal capillary non-perfusion, which eventually leads to tissue hypoxia and consequently retinal ischemia. Retinal ischemia will lead to a release of the vascular endothelial growth factors. Now, vascular endothelial growth factor, when it's released, it's not target specific, and therefore it can cause neovascularization anywhere in the eye. It could be neovascularization at the disc, elsewhere, or at the rubeosis, at the iris, which is neurorubeosis iris. Now, what happens when you have neovascularization? The neovascularization can be limited to a preretinal hemorrhage. It can cause a subhyaloid hemorrhage, leading to a vitreous hemorrhage. Or if you have neovascularization, the new blood vessels, they grow into the vitreous. This can lead to fibrovascular proliferation with fibrous glial tissue proliferation. Eventually, these blood vessels, because of the microvascular occlusion, they close up. There can be a contraction of the fibrovascular proliferation, which can lead to traction on the retina and a tractional retinal detachment. And it can also lead to a combined RD, which is a traction plus rhegmatogenous retinal detachment. Neovascularization of the angle and neovascularization of the iris can result in neovascular glaucoma, which can eventually lead to optic atrophy and an absolute painful eye. So as you see in the pathophysiology, it can lead, diabetic retinopathy can range from very mild disease to very, very severe disease. This is evident from the hypoxia that occurs because of the vascular occlusion. So here you see that there is a hypoxic retina because of microvascular occlusion between the artery and the vein. Because there's a loss of the connection between the artery and the vein, there are AV shunts that are formed at different levels in the retina, and these are the intraretinal the ERMA. This also, because of the hypoxic retina, you can also get neovascularization of the iris, neovascularization of the angle, and proliferative retinopathy. So what are the clinical features? If you're looking at a patient who comes into your clinic, on the left side, you will see a normal retina with the retinal blood vessels, the macula, and the optic nerve. And on the right, you will see a patient who's, this is an image with diabetic retinopathy in its full-blown form, where you see neovascularization of the disc, neovascularization elsewhere. You see microaneurysms, edema, and exudates, and you see cotton wool spots, which are basically infarctions at the nerve fiber layer level. So when you're examining a patient of diabetic retinopathy, the earliest sign of diabetic retinopathy is microaneurysms, which appear as tiny red dots scattered mainly at the posterior pole. Histopathologically, they are located in the outer plexiform layer and the inner nuclear layer. Hello.
Yes, doctor, it's audible.
Yeah, I seem to have a blank screen. I'm sorry. I'm just trying to rectify it at my end.
We are seeing the microaneurysm picture.
Okay, so I am unfortunately not able to see anything. So I'm just trying to rectify. Just give me a second, please.
Yeah, no issues.
Sir, please comment tab or alt tab, please select, sir. Your laptop, alt tab or comment tab.
Okay. Doesn't seem to be working.
Doctor, please stop the share screen. Again, do the share, sir.
Hello, good evening.
Ravi?
Yes,
Yeah.
doctor.
Can you check with Dr. Hassan and Shikhari what is
Madam,
happening?
left the meeting, madam.
Oh, his connection was at fault?
Yes, madam. I think some internet issue from.
Okay, no worries. Dr. Preeti, can we go ahead with the next topic? And probably we can have his next.
Next topic, Dr. Preeti.
Yeah.
You want to go to the next topic?
Yeah, because he's
Okay.
disconnected from the meeting, so he has to join back.
Okay. Okay. So Parveen ma'am is there, right?
Yeah, she's there.
Okay. I'd like to invite our next speaker, Dr. Parveen Sen, to talk about basics of retinal detachment. Madam is one of the leading vitreoretinal surgeons in the country. After graduating from Punjab, she has done her VR training from the Premier Eye Institute, Shankar Nethralaya, Chennai. And she has worked with Shankar Nethralaya for close to 22 years as a senior consultant. And during her tenure at Shankar Nethralaya, she has gained experience in doing complicated vitreoretinal surgeries. And she's a renowned pediatric retinal surgeon and known all over the country for her work in pediatric retinal surgery. I'd like to invite ma'am for her talk.
Thanks, Preeti, for the introduction, and I welcome you all to this session. I apologize that we had some issues with the very nice talk which Dr. Hassan was delivering earlier. I'm sure he'll be able to continue later. So in the meantime, I would like to take you over to the basics of retinal detachment here. So I hope my slides are visible already, right?
Yes, sir.
So, so since we are here as a teaching session for the postgraduates and students, I would like to first begin with the basic, and that is what is basically retinal detachment. When we say it is the neurosensory detachment, and that is happens because during the pathogenesis or during the embryology itself, there is this potential space because of this peculiar process of development of the eye and the separation of neurosensory retina as well and the RPE is something which is actually already present. So this potential space, when it becomes real with the or increases because of the presence of subretinal fluid, is when we get retinal detachment. So the physiological forces which keep this retinal attachment intact is the presence of interphotoreceptor matrix, which is present in the subretinal space. This is the potential space which is there between the two layers, and the oncontic pressure difference between the choroid and subretinal space, which actively pumps out the fluid from the subretinal space. The hydrostatic or hydraulic forces which are related to the intraocular pressure and the active metabolic transfer of ions and fluid by the pumping action of the RPE. That is what maintains this retinal attachment and does not allow the separation to happen. So depending upon the etiology of the retinal, this separation or retinal detachment, you could have a rhegmatogenous retinal detachment, a tractional retinal detachment, or an exudative retinal detachment. And the tractional, as the word suggests, is because of the traction above, which could be because of the formation of the fibrovascular tissue on the membranes. And so you can see that the retina is taut and it is concave unless you have development of a rhegma in addition to the fibrous tissue, in which case we call it the combined retinal detachment. This is an element of traction as well as rhegmatogenous component. So the common features which differentiate different kinds of detachment is that convex configuration or bullae which can be present. This can be either due to an exudative retinal detachment or rhegmatogenous retinal detachment. And the gravity dependent fluid which settles down, giving rise to what we call the shifting fluid, is more common in exudative retinal detachment. And you will have a clear fluid in cases of a rhegmatogenous retinal detachment, but turbid fluid in cases of exudative retinal detachment or a long-standing rhegmatogenous RD also. So as I said, the typical feature of exudative retinal detachment is the shifting fluid, which is a very important clinical sign. But we must remember, though it is said to be almost synonymous with the exudative RD, shifting fluid can sometimes be present in long-standing rhegmatogenous retinal detachment also, specifically if you have small retinal holes, so that the fluid is accumulating there for a long period of time. So this is another example of exudative retinal detachment, and you can see in this case it is subretinal inflammatory mass which gives rise to this kind of exudative RD, and the other causes are neoplastic or inflammatory. So the basic physiology of exudative detachment is that there is a potential breakdown of the two main retinal barriers which are present, which is in the RP cells and this is compromised, the outer blood retinal barrier or the inner blood retinal barrier. When this is compromised, it gives rise to increased exudation and causing exudative retinal detachment. So the causative mechanism of rhegmatogenous retinal detachment is presence of a rhegma or a hole. In case of tractional RD, it's the presence of traction caused by the membranes which are formed on the surface of the retina. In exudative, it is usually because of the breakdown of the blood retinal barrier. Differentiating features, rhegmatogenous will have a convex configuration, tractional or concave elevation. Exudative again is due to convex elevation. Shifting fluid can be seen largely in exudative RDs, sometimes in rhegmatogenous RD. And we will go in and look into the examples and treatment in our subsequent slides. So this is the differential diagnosis. Whenever you see elevation of retina from the underlying layers, you have to think of retinal detachment and its etiology, whether it is exudative, tractional, or rhegmatogenous. Other features can be a degenerative retinoschisis can present as an elevation of retina in which there is split of the retinal layers, or it is a choroidal detachment, in which case the separation happens not between the neosensory retina and RPE, but between the RPE and the underlying choroid. Uveal effusion syndrome is one form of exudative retinal detachment, and this can also sometimes old and organized, which looks like almost like a membrane as if the retina is detached. So you need to be careful with this. So how do you differentiate it from a retinoschisis? Usually retinoschisis gives rise to smooth, immobile, dome-shaped elevations. And if you do field examination, because it is a split of the retina which causes it, the visual field defect is usually absolute. And in cases of retinal relative, but in cases of old RD, you can have a absolute kind of a defect as well. How do you differentiate it from a choroidal detachment? Most importantly, usually the vision may be better in cases of a choroidal detachment as vis-a-vis a retinal detachment. Appearance can be convex, and you will have a brownish look into the elevated membrane which is present. And usually it is in the periphery and then comes in the center in cases of a with a combined choroidal detachment. And IOP is usually very low until unless you are having hemorrhagic choroidal detachment, in which case your intraocular pressure can be very high. So as I discussed, exudative can be due to underlying tumors, or it can be inflammatory. So with this kind of an overview of the different types of retinal detachment, I think I'll concentrate from here on to the most common and something which we deal with day in, day out, that is a heterogeneous retinal detachment. And as name suggests, it is due to the presence of a regma or a break in the neurosensory detachment in the neurosensory retina. So this is the main pathology. There is a break which is present, and if the vitreous is formed, that can plug it. But if it is liquefied, which can be because of vitreous traction or because it is with the age, the vitreous does liquefy. Because of this gap or because of this regma, this liquefied vitreous finds access into the subretinal space, causing this potential space to become very real and elevation of the retina. So retinal breaks can form largely due to the presence of the vitreous traction, but it can sometimes be there because of associated lattice degeneration. And important question that you can often be asked is if it is surrounded by a cuff of SRF, which is more than 1 dB, it is known as a class. If it is less than 1 dB, we call it a subclinical RD. More than 1 dB, it's an obvious retinal detachment. So this is how a typical horseshoe tear looks like, and usually there is presence of vitreous attraction along this anterior flap. And this is an operculated break. You can see carefully, this is the operculum which is present here, so which means a tag of retina is completely separated from the retina below. This is a giant retinal tear. Anything more than 90 degrees of circumference, if it is present, it is called a giant retinal tear. These are the small holes which may be present in lattice degeneration, and this can also give rise to retinal detachment. Peripheral retinal dialysis, more often seen in the young, and secondary to trauma. Whenever patient gives a history of trauma, you must carefully examine the periphery to look for the presence of a dialysis. Predisposing factors for any kind of horseshoe tear or HST is the presence of PVD, high myopia, history of complicated cataract surgery, patient is aphakic or pseudophakic, history of trauma, predisposing peripheral retinal breaks, and systemic diseases, especially when you see multiple and 360-degree circumferential lesions. Do think in terms of systemic underlying diseases like Marfan, Stickler's, or Ehlers-Danlos syndrome. So when these predisposing factors are present, you must think of treatment. And would you treat all peripheral retinal degenerations with photocoagulation to prevent retinal detachment? Well, some of them, especially things like paving stone degeneration, pars penosus, you can easily wash them because they're associated with very low risk of retinal detachment. But things like lattice degeneration, snail track, maybe plus minus, but definitely lattice degeneration, horseshoe tears, these can be associated with a high risk of retinal detachment and must be treated. So once you have seen retinal detachment, how do you go about it? So first of all, evaluate for the symptoms. Patient may be totally asymptomatic or may present with flashes of light, floaters, or most commonly drop in vision, especially a shadow-like or a curtain-like thing falling in the peripheral field of vision. And signs would be decreased visual acuity, RPD. IOP is usually low. So if you have any doubt whether you are looking at a shallow elevation of the retina and you're not sure whether the retina is detached or not, look at the IOP. If IOP is low, and you're definitely looking at a retinal detachment. And iritis, NVI can be present in acute cases also, iritis, and in old standing cases, NVI. Schaffer's sign forms due to the tobacco dusting in presence of retinal breaks. So this is what a fresh RD may look like. Presence of these corrugations is kind of very typical. And you can see this is what is meant by a convex configuration. Old standing RD may have these cysts or maybe the presence of a demarcation line, and this is where you can see sometimes demarcation line. Just be careful when you examine. Not all these yellowish things are definitely subretinal glyphs. Sometimes this demarcation line looks like this, and all that you need to do use a simple buckle to reattach it. You can further confirm the diagnosis by wide-angle viewing system these days and or ultrasonography. This is a very important test when you do ultrasonography. See this, look at typically the movements. One is that this, look at this membrane, which is completely mobile. This one below is a posterior vitreous detachment, while this one is tethered at the optic disc. So something which is tethered at the optic disc is most likely to be RD. And look at the echogenicity. Even if you trace this membrane in the periphery, it's a fairly highly echogenic membrane, and this goes in favor of a retinal detachment. So this is another example of the ultrasonography, the B scan. You see this tenting which is present here. Here again, the tenting is present. These are more in favor of attractional retinal detachment. Exudative, you can see this is in the lying down position, and this is in the sitting position, position where the fluid is all gravitated away from the posterior pole. So this could give you the suspicion of an exudative component. OCT, especially when these corrugations are present, are more suggestive of a heterogeneous retinal detachment. This is what a tobacco dusting or Schaffer's sign would look like. Fundus drawing is of utmost importance. Careful examination of the retina with indirect ophthalmoscopy, and you mark out each and every break is very important. Must remember that even whenever you are planning surgery, especially scleral buckling, the view intraoperatively may not be as great as the preoperative view. So you must mark all the breaks very nicely and have a plan in hand before you go and take up the patient in the OR for scleral buckling. These days, with wide-angle viewing systems, a preoperative photograph can be as good as a fundus drawing. You can see, you can make out all the details here. The large break, presence of an edge tear here, there's a lattice here, there is a pigmented lattice here, and you can see there's another break here. So all these things can be well mapped out. The presence of proliferative vitreoretinopathy will determine what kind of surgery you would do, and this you must look for it. So this is how you examine, and this is how you classify. This is the modified classification, where A and B is just presence of vitreous haze and some wrinkling and the presence of tobacco dusting. So A and B, definitely you can go ahead with scleral buckling. But if you look at posterior pole and you see the fixed folds, CP means posterior fixed folds, and CA means anterior or circumferential kind of PDR, which may be in the form of subretinal strands as well, then definitely, especially if it is more than 1 or 2 clock-hours, you have to go in for vitrectomy. D is actually from a previous classification, but you can use it because helping prognosis. D1 is wide funnel and narrow funnel or a closed funnel retinal detachment. Management, they are the most important aspect of RD surgery is to close the retinal breaks. So how you're going to close it? If you do it, first of all, identification. This is an important Linkoff's rule which you must remember. So if you have RD which is inferior and you have one side the RD is higher as compared to the other, the break would be towards that side. It will be an inferior break, but towards the side where the fluid is higher. If both sides are equal in an inferior RD, break will most likely be at 6 o'clock. If you have this kind of a trailing of SRF, then usually the break is somewhere here. And if you have again fluid which is crossing the midline, the horizontal meridian, usually the break is above the horizontal meridian. If you have only a small wedge which is attached and it is higher on one side, it usually is a small break here close to the ora superiorly, which is off, then usually look for 12 o'clock for the break. The surgical techniques are usually basically 3: scleral buckling, partial vitrectomy, and mimetic retinopexy. Scleral buckling is the gold standard, but this is rapidly changing now because partial vitrectomy is becoming safer and more accurate. And in certain cases, pars plana vitrectomy is the choice. So the required buccal element would depend on the number of breaks and the size and how it is long-standing, or you may not need to drain subretinal fluid every time. So this is a common mistake that people made, that how will you reattach if subretinal fluid is not drained? As long as your break is apposed on the buccal, the retina will get attached without your draining the subretinal fluid. You need to drain it only if it's a long-standing RD, bullous elevated detachment, or no visible breaks, and coexistent glaucoma, because the pressures will become high if you put a scleral buckling element. Scleral buckling is especially preferred if there is presence of anterior retinal breaks and dialysis, especially in young patients. Always think of scleral buckle first before you decide to go in. Complications can be during the procedure, which is something like accidents, retinal perforation, incarceration, subretinal bleed, or vortex vein dissection. Post-operative long-term, you may have buccal infection, migration or extrusion, or you have recurrent RD or choroidal detachment or hemorrhagic choroidals. Pars plana vitrectomy is another technique, especially if you have media opacities and you cannot map your retinal breaks very well. You will have to go in and treat accordingly. And if there's a posterior located break where you cannot buckle it, or there is presence of PVR, or there's a giant retinal tear or associated macular hole, these are all indications that you will have to go in with the pars plana vitrectomy. So in principle, once you do core vitrectomy, you have to clean the peripheral base, remove the vitreous from the surface. So just, you may not need to know all the details now, but just to give you an overview, you have more of what is called the sutureless vitrectomy, where you can go over the conjunctiva and right across it. And this is an example, how do you make these sutureless entries. It is transconjunctival, and sorry, I tried to hurry up the video, but it got stuck. Give me a minute here. So here, there is no need to suture these sclerotomies, and you can just close it there. Just 1 second. Let me just get out of this. I'll share again.
Please remember it.
Ma'am, Dr. Parveen sir.
Yeah, just 1 second. I think the videos got stuck. I'll just try to re-share with you.
Sure, ma'am.
Sometimes that gives a problem. I'll just join you again after I. Okay, you just need to allow me to share my screen again.
Admin?
Yeah, yes, madam. Yes, madam.
Yeah, please.
Doctor, now you check, madam.
Yeah.
Okay.
All right. I think I'll just skip the video since it's giving a little bit of a trouble and continue my talk otherwise. Yeah. So you have to be wary of these complications which can occur in vitrectomy. You could have simple things like iatrogenic break or lens damage, and post-operative may be presence of PVR or recurrent retinal detachment. So I'm going to skip the video again. I don't want to take a chance. It would spoil the thing. So vitreous substitutes, again, are the substances which are used to are injected into the vitreous cavity to make up for the volume replacement. And they serve as tamponade if they help you
Ma'am, we are not
the
seeing the PowerPoint. We are just seeing the screen as such. The PowerPoint we are not able to visualize.
Are you not seeing my PowerPoint?
No, we are seeing the screen showing exudative RD, new final, retinal detachment, retinal PPT, all that we are able to see. The basics of RD, yeah.
Now are you able to see? No.
No, ma'am, you haven't started sharing. Yeah. Yes, ma'am.
Okay. So I was at the tamponades. How do the tamponades work? So this is silicone oil is one of the most common tamponade which is used, and that is because it is transparent and it is FDA approved and high viscosity. So it is available in different viscosities. Lower viscosity means ease of use. Higher viscosity means difficult to inject as well as remove, but then advantages in less chance of emulsification. And indications would be severe PDR, giant retinal tears, choroidal coloboma, inferior RD, especially pediatric retinal detachment and trauma. So, and silicone oil tamponade gives you a prolonged tamponading effect, but the disadvantage is that you needs a repeat surgery to remove the silicone oil. It can cause cataract, it can cause increased IOP. But the advantage is a early visual rehabilitation. So usually the recommended time for removal of oil can be as early as 6 weeks or even shorter. Once the laser has taken its effect, silicone oil can be removed, but it can be left longer if there is chronic hypertonia. And these are the complications which can happen because of silicone oil. This is something which you see inverse hypopyon on the left, emulsified oil, and because it is lighter, you have it inverse hypopyon. This is subretinal silicone oil. This is silicone oil in the anterior chamber. And this is long-term silicone oil present, giving rise to band-shaped keratopathy. Secondary glaucoma, because of oil, can happen because of pupillary block, overfill of oil, and migration of oil in the AC. Important thing, once oil is inside, if it is a phakic patient, you see that oil forms a concave meniscus. And because of this, you get a hyperopia of induced hyperopia of about +5. Vis-a-vis in an aphakic patient, you see that the oil is now forming a convex configuration, because of which aphakics actually become less hyperopic. PFCL is another tamponade. It can be used, it is heavier, so it settles down. People have used it for, most common usage is to open up a giant retinal tear. But disadvantage of PFCL is it can be used only for a shorter period of time, because longer if you leave PFCL inside, then it can cause PVR and inflammation. Third most important tamponade is intravitreal gas. You can use it either diluted or undiluted. Undiluted, we use it in form of pneumatic retinopexy, where a small expansile bubble, usually about 0.3 ml, is used. And as it expands, it blocks the retinal break. So this can be used as a procedure in a small retinal detachment, fresh RD, single break retinal detachment, superior breaks. So this can be used as a procedure. But if you have inferior breaks, PVR is present, multiple breaks in various clock hours, usually pneumatic retinopexy may not work. So various kinds of intraocular gases have been used. The non-expansile are air, most common, and expansile is SF6 and C3F8 are the most common ones. Air, if you inject, usually you do not have an expansion, but SF6 becomes 2 times the size in 36 hours, C3F8 4 times, and C2F4 somewhere in between. Why does it expand? So into the bubble, you have the diffusion of nitrogen and oxygen from the blood, and this causes expansion of the bubble. And then comes the phase of equilibrium, in which outward movement of the gas and inward movement of nitrogen is equal. So there is no further expansion, and then where the net gas exit is more, then there is dissolution. So this is how, because of its buoyancy, it works as an ideal tamponade. So the choice of gas will depend upon how much long tamponade you need, and contraindications, as I said, if it is an inferior one, usually gas does not work. And complications is that important aspect. If you're going to give GA, then you have to make sure the nitrous oxide is not used as an anesthetic agent. Prone position is required after gas or oil. These are the complications which can happen, that is pupillary block, and cataract, inadequate fill, subretinal gas. And advantage over oil is that you need not have a patient undergo repeat surgery for removal. So the disadvantage is air travel has to be avoided, post-op IOP increase, development of lens opacity, and visual rehabilitation is delayed. Last point in the management of RD is the evaluation of the fellow eye. So make sure you don't miss this. So if any fluid is seen or any breaks are seen, or a patient is high myopic, look for peripheral lesions and treat them. That's it. I hope I have summed up a large topic. I apologize for having taken a little longer.
Thank you so much, Dr. Parveen. So it was really good. You took us through the basics of the retinal detachment, discussed the differential diagnosis, PVR, and the management in detail. Thank you so much for taking us through. And the last topic, we were halfway through, and because Dr. Hassani Shikari lost connection, we were not able to complete it. We will continue with the diabetic retinopathy. We welcome you, Dr. Hassan Shikari.
Great. I apologize again for the abrupt discontinuation of my talk. Can you hear me?
Yes.
Okay, so we will take off from where I believe we shut down.
Yes.
So we were discussing what the clinical features of diabetic retinopathy are. When you have a patient who presents to you with diabetes and you take a look at their retina, the earliest sign of diabetic retinopathy is a microaneurysm, which appears as tiny red dots. These are usually present histopathologically in the outer plexiform layer or the inner nuclear layer. Mainly at the posterior pole and especially temporal to the fovea. You'll also see them more parafoveally. If you're going to be doing an angiography, you will see them at the edge of the area of capillary non-perfusion. So there'll be hyperfluorescent dots present over there. The other common clinical feature are retinal hemorrhages. These can be two types. They can be dot plot hemorrhages, which are due to the rupture of the capillary wall or a microaneurysm. And these are usually intraretinal hemorrhages. If they're deep into in the inner layer of the outer plexiform layer, is usually round or oval. And you can have flame-shaped hemorrhages, which are from superficial precapillary arterioles. And if it's in the nerve fiber layer, it forms a splinter hemorrhage, because they follow the architecture of the nerve fiber layer. Another clinical feature is exudates. Now, exudates are basically deposits of lipid, lipoprotein, and lipid-filled macrophages within the outer plexiform and inner nuclear layer. They are a result of leakages from microaneurysms, and they form a circinate pattern, which is basically a circular pattern in a clump form. These are the signs of current or previous macular edema, and you will usually see them at the posterior pole. They are white, fluffy, and then we have cotton wool spots, which are basically soft exudates, which are white, fluffy lesions in the nerve fiber layer as a result of infarction of the NFL. Coming to intraretinal microvascular abnormalities, these are abnormally dilated and tortuous retinal capillaries that act as a shunt between the arterioles and the venules, as we discussed previously. And this is because of the microangiopathy leading to occlusion of the AV shunts initially. These are usually present within the internal limiting membrane. Some patients may also present with venous changes in the form of beading, looping, and severe segmentation due to venous stagnation. Now, how do you classify these diseases? Classification is important because when a patient presents to you based on the severity of the disease, the treatment sometimes changes, and as does the prognosis in these kind of patients. So mild, we basically classify these patients into non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. NPDR or non-proliferative is further classified into mild, moderate, severe, and very severe. So mild NPDR patients usually present with scattered microaneurysms, a few retinal hemorrhages, and hard exudates. If a patient in addition has cotton wool spots, venous changes, and intraretinal microvascular abnormalities, then the patient is classified as a moderate NPDR. A severe NPDR follows the 4-to-1 rule, which essentially means that the patient presents with signs of moderate NPDR plus any one of the following, which is microaneurysms present in all four, or retinal hemorrhages present in all 4 quadrants, venous changes present in 2 or more quadrants, and intraretinal microvascular abnormalities present in at least 1 quadrant. Very severe NPDR has 2 or more of the above features on severe NPDR. So you would have features of moderate NPDR plus 2 of the following 3. Proliferative diabetic retinopathy is the presence of neovascularization at the retina. This can be non-high risk or high risk. High risk characteristics basically mean there are presence of new blood vessels at the disc, which is NVD, where more than 1/3 of the optic disc diameter is present with or without hemorrhage, or there's less than 1/3 optic disc diameter involvement with a preretinal or a vitreous hemorrhage. If there's neovascularization elsewhere in the fundus, which is more than half optic disc diameter without hemorrhage, or less than half of optic disc diameter with a preretinal or vitreous hemorrhage. Another entity in diabetic retinopathy is the presence of clinically significant macular edema, or CSME. This is classified by the modified Early-House criteria, which includes retinal edema within 500 microns of the center of the fovea, hard exudates within 500 microns of the fovea centralis associated with adjacent retinal thickening, or retinal edema that is 1 disc diameter or larger, any part of which is within 1 disc diameter of the fovea. So now coming to the management, the most important thing is you need to go through the entire history from the patient, the duration of diabetes, presence of any existing comorbidities, the control of sugar, the hyperglycemic episodes, the hypoglycemic episodes. This is coupled with clinical features which can be seen on examination. The patient don't go always by the best corrected visual acuity, because sometimes these patients can present with very severe N6 as well. So in my clinic, all the patients who come with diabetes undergo a dilated eye examination. The way I usually do it is I do indirect ophthalmoscopy first to get a basic overview of the fundus, and then I do a 90 diopter indirect ophthalmoscopy with slit lamp biomicroscopy. In terms of investigation, the standard laboratory investigations such as blood sugars, lipid profile, and medical evaluation of HbA1c. I prefer the presence of HbA1c over FBS and postprandial blood sugar, just because it gives me a better overview of the glycemic status of the patient. Ancillary tests that we can do in clinic include a color fundus photograph, a fluorescein angiography, and an OCT if you're suspecting any sort of macular edema. So here, this is a young patient, about 40 years of age, who came in for a routine checkup. The patient had no complaints on probing. The problem that we have here is that, a lot of patients, you ask them, do you have diabetes? And they tell you, no, I don't have diabetes. But then on further probing, it comes out that, they're taking medications for diabetes. So they think they don't have diabetes, but they basically have diabetes, which they think is under control. Now, this patient was, dilated in clinic, and this is what we found. So if you see the color photo on the left, you see that the patient has proliferative diabetic retinopathy with neovascularization. Elsewhere, he's got traction bands, fibrovascular proliferation. We did an angiography of the patient, and you can see gross leakage with capillary dropout areas and areas of non-perfusion in the far periphery. This patient underwent laser treatment, which is pan-retinal photocoagulation, and he's doing pretty stable now. So the treatment options that we have, the tried and tested treatment options are laser, which could be focal laser or grid laser in case you're treating lesions at the posterior pole, and pan-retinal photocoagulation, which basically implies a laser to the periphery of the retina. There's also intravitreal injections of antivascular endothelial growth factor, which can help reduce the presence of neovascularization and also in cases of macular edema. So what are the indications of the laser? So if you have grid or focal laser, the major indication is a clinically significant macular edema, where based on the fluorescein angiography, you are targeting the vascular leakages or microaneurysms in the parafoveal area. The grid or focal laser is safer because the burns are more controlled and a smaller size, and hence are visually sparing. There are also certain micropulse lasers which are now being used, or the yellow laser, which do not cause a lot of scarring and also equally helpful in getting rid of the macular edema. Pan-retinal photocoagulation is indicated in cases of severe NPDR or proliferative diabetic retinopathy with high-risk characteristics or early PDR, in patients with whom you suspect are going to be poorly compliant with coexisting systemic diseases, a patient in whom a cataract surgery is pending, or a patient who's presenting with neovascularization in the anterior segment. So focal laser, like I just mentioned, burns only the microaneurysm. A grid laser, you do target around the edema, except the foveal avascular zone. And a pan-retinal photocoagulation burns the viable retina in the periphery. So basically, you're reducing the ischemic retina, and hence you're reducing the amount of VEGF that is being produced by a hypoxic retina. Now, the newer modalities, what is basically boils down to anti-VEGF, VEGF or VEGF inhibitors, or vascular endothelial growth factor inhibitors, are humanized monoclonal antibody fragments which bind with the free VEGF and cause neutralization of the VEGF, so it can't bind to the receptors, and therefore reduces vascular permeability, inhibits leakage, and reduces macular edema. They are also useful in neovascularization. Commonly used are bevacizumab, ranibizumab. We also have newer molecules such as aflibercept, brolucizumab, though the indications in diabetic macular edema are limited. Complications are very rare if performed properly with full aseptic precautions, but a patient can present with subconjunctival hemorrhage, cataract if your needle has not is not directed properly. Certain patients can present with glaucoma, a vitreous hemorrhage, endophthalmitis, and retinal detachment. Thankfully, are very, very rare. So when it comes to diabetic macular edema, I think persistence is a pathway to success. Here, this is a case report with a 75-year-old male patient, diabetic with macular edema in the right eye, which showed a gross macular edema. It was treated with an injection of anti-VEGF in the eye. We repeated the OCD scan in 6 weeks and shows there was some response, there was some decrease in edema, but the swelling still persisted. So we performed another injection, and this time we coupled with a steroid. Repeat 6 weeks later after the second injection of anti-VEGF and steroid shows complete resolution. The vision did not improve, but anatomically there was a resolution of the macular edema. So thank you. If there's any questions, I can address them right now.
Thank you, Dr. Shikari, and thank you so much for accommodating this on a last-minute notice. And I think you've covered diabetic retinopathy, which is a very basic and important topic in our day-to-day OPD in a very elaborate manner. Thank you so much, sir. And if there are any questions, we could take them on the chat box, and we'll probably answer them at a later time. Thank you so much, sir.
Thank you.
I'd like to call upon our next speaker, Professor Dr. Kasinathan, to talk about macular pathologies. Dr. Kasinathan sir is a very experienced ophthalmologist and a VR surgeon, hailing from the School of Shankar Nethralaya yet again. He did his fellowship from Shankar Nethralaya and subsequently continued there as a consultant in vitreoretinal services until 2011. And sir is actively involved in training many fellows and postgraduate training and thesis guide also to them. And he is a principal investigator for multinational clinical trials and also as an examiner for FRCS Glasgow. He's also the founder and patron of Retina Interest Group of Chennai. I'd like to invite Sir for the talk.
Thanks for those kind words, Preeti. Actually, I should say we should swap the talk between myself and Parveen Sen madam, because she's a pediatric ophthalmologist, excellent in all the electrodiagnostics. I think the talk should have been swapped. Anyway, pardon me for any flaws in the talk, and I'll share my slide now. What is asking system preferences and all? Okay. Is my slides visible?
No, sir. You haven't started sharing.
No,
You
sir.
haven't started sharing.
Usually it goes, okay. Lock. Oh, it suddenly changed something settings.
Ravi, can you help?
Doctor, Windows system or Mac system, doctor?
Mac.
Okay, doctor. Please select the share screen.
1 second. Yeah, I'm just putting the share.
Any blue color it's showing, doctor? Amper signal something?
Desktop, whiteboard, iPhone, iPad, all the boxes are coming.
Desktop, sir. Desktop. Please select the desktop.
Desktop, it comes like an exclamation mark. Share. And
yes, sir. Yes. Please select the exclamation mark.
I have selected it. It goes on. Open.
Yes, correct, sir. Correct, sir.
And then it says open system preferences.
Yes, correct, sir. Select open preference.
Okay, opened it.
Then on the left side, one small lock button is the bottom small lock button. Select the lock button. Enter your password. System password, sir.
Yeah. Okay. Now select Zoom, right?
Yes, correct, sir. Now you share, it will come.
Zoom will not be able to record that. Okay.
Yes,
Yes,
sir.
sir. Yes,
Thank
sir.
you.
Thank you so much, Ravi.
I'll go to the full screen. Yeah. So thanks, Team Agarwal, for having me for yet another PG class. As I said, the talk should have been swapped between me and PK ma'am because she's too good in pediatric retina and electrodiagnostics. And so I'll be talking on macular pathologies. And basically, the macular pathologies could be either infective or hereditary, the most common one, hereditary ones, or the infective ones like cysticercosis and toxoplasmas, and acquired one like AMD, diabetic retinopathy, hypertensive retinopathy, maculopathies, and vascular like choroidal hemangiomas. Sometimes traumatic, you can have macular scar, macular holes, and congenital like retinoschisis. So the macular pathology broadly falls into these categories. And the next one. Oh, it's not moving. Okay. And also the macular pathologies can be classified as a medical macular pathology, which can be treated with pharmacotherapy like injections or drops like iridomacular degenerations, infective or acquired, or the surgical maculopathies like vitreomacular traction, macular holes, and ERMs, which needs a surgical intervention. So being a postgraduate class, I thought basically I should concentrate on hereditary retinal disorders. Along with that, I have some acquired and other retinal disorder macular pathologies to show. So coming to heredomacular degenerations, they brought, most of them are familial and early age of onset, and they have marked decrease in vision. And most of the heredomacular degenerations are bilaterally symmetrical, and they have characteristic retinal changes which help us to clinch on the diagnosis. And most of the heredomacular degeneration, they don't have systemic or physical or laboratory abnormality. It's basically on clinical fundus examination and the patient's history, you'll be able to make the diagnosis. And the symptoms, most of them will have a decrease near vision or the macular pathology. That's one of the distinction and point between a macular pathology or a retinal pathology or a lens cataract related problems. The cataract usually affects the distance vision, whereas the macular pathology or any retinal pathology for that say will affect the near vision. And most of the patients will have metamorphopsia, which means abnormal distorted vision in the central, and they can have central scotoma like in a macular hole, or the objects may look smaller, as we call it as a micropsia, or may they look bigger because they call it macropsia. Hemeralopia is again a difference in colors which is noticed, or sometimes even it is said as photoaversion, or the photopsia, which means photoaversion. So the macular problem, most of the macular problems will have any of these symptoms. And the hereditary macular dystrophies are basically classified into the layer which is primarily affected. Basically, they can have a photoreceptor or sensory retina dystrophies, or an RPE dystrophy or a choroidal dystrophies. So starting with the cone dystrophy, most of them will have a decreased visual acuity and decreased color vision. And being a cone dystrophy, they'll have photoaversion or hemeralopia. And being early onset, most of the dystrophies which have an early onset, they will have nystagmus. So the fundus either may look normal or they may have an absent foveal reflex. Sometimes there can be a pigment stippling around the macula. And the classical description in a cone dystrophy is what we call bullseye maculopathy. And sometimes they can have a temporal pallor of the disc. And this is a classical ERG. You can see the cone dystrophy can be either autosomal dominant or recessive or X-linked. This genetic workup may help us to prognosticate as well. Because if it's an autosomal dominant, most of the time they are progressive, whereas autosomal recessive is a non-progressive variety. And the ERG, they will have a classic decrease in photopic response because being a cone dystrophy. And the scotopic amplitude may be variable. In the late stages of the cone, where they become a cone rod dystrophy, they may be affected. But initial stages, it's basically the photopic response is decreased. And the other differential diagnosis of bullseye maculopathy is one of the exam MCQ questions. It can be seen in cone dystrophy, most common. It also can be seen in Stargardt's or Leber's hemerosis, Bardet-Biedl syndrome, and chloroquine toxicity. Then coming on to juvenile retinoschisis, it's X-linked recessive, and there is 100% penetrance, and there is a decrease because it affects in the very early age of life. There is nystagmus, strabismus, and they will have an hyperopic shift. And foveal schisis is universal, and 50% may be associated with the peripheral schisis. And then you can see the ERG classical negative ERG waveform, which is seen in foveal schisis. And you can see this is one of the, when you clinically see, this looks like a macular hole. But OCT is like an in vitro histology of the retina. It gave beautiful, especially the macular pathologies have been well described and become very, each and every layer of the retina can be dissected with OCT, and OCT has really revolutionized the macular understanding of the macular pathology and treatment of macular pathologies. Here you can see clinically it looks like a macular hole, but when you do an OCT, you can see there is a thin layer of retina, so sensory inner layer retina on the top, and you can see the schisis. See, if you do the differential between a macular edema and a schisis, in a macular edema, all these empty spaces goes towards the macula, or center of fovea, what we call it as a flower petal appearance. Whereas in schisis, you can see vertical bridges from the inner layer to the outer layer of the retina, you can see vertical bridges. And this is the differentiating point between a schisis and a macular edema. And then juvenile retinoschisis, they'll have inner layer breaks are larger because inner layer breaks are seen in the inner sensory retina. These breaks are larger and irregular. So having an inner layer break alone doesn't lead to retinal detachment. If they're associated with the outer retinal breaks, then it leads to retinal detachment. And schisis usually does not extend to the ora, unlike a retinal detachment. Usually they don't cross the posterior pole. And if it crosses the posterior pole and extending to the ora, it means they are having outer retinal breaks. And the outer retinal blades, because the retina is a little thicker, the outer layers, they are usually circular and very regular. And then the complications of retinoschisis, they can have present with vitreous hemorrhage, and incidence of retinal detachment is around 40%. And usually when you have retinal detachment, there is a break in the inner and outer layers as well. And coming to Stargardt dystrophy, the most common form of dystrophy which is seen clinically, it's autosomal recessive dystrophy. And it may look normal fundus initially, and in later stages, they can have beaten bronze appearance and flex, which is one of the commonest type of fleck retinal syndromes. Here you can see a beaten bronze appearance in the macula, bilateral, and here you can see the stipulated posterior pole window defects. And FFA, they have silent choroid, but silent choroid is not pathognomic of Stargardt dystrophy. It is not a pathognomic. It is present only in 30 to 40% of Stargardt patients. So this should not be a pathognomic finding of a Stargardt disease. And they may have transmission defect. That's because of the RP atrophy. And the silent choroid is because of the diffuse acid mucopolysaccharide deposits in the RP. That causes the silent choroid in an FFA. And ERGs varies, usually subnormal only in the later stage of the disease. And then the best disease is an autosomal dominant form of variety, and it has a classic fundus appearance like an egg yolk appearance. And there are various fundus signs, which I'll come to that later. And they have a subnormal EOG, and best disease is the problem of the it's a retinal pigment epithelial dystrophy. So here ERG, see all the retinal dystrophies, ERG is very important. All the RP dystrophies, EOG is important. So, and here you can see the pseudo-hypopyon or the egg yolk appearance, and here you can see scrambled egg appearance. Here you can see scrambled egg appearance. Here sometimes best disease in the later stage after the scrambled egg appearance can be associated with the CNVM. You can see a subretinal hemorrhage. These are the various stages of a best dystrophy. And no treatment is available. Only when you have a CNVM, yes, anti-VEGF may have a role. And usually the prognosis is good. Even having an egg yolk in the macula, the visual damage is not that much. And this egg yolk is nothing but lipofuscin deposits in RPE, and the classical or pathognomic electrodiagnostic EOG, where they have a subnormal Arden ratio less than 1.5. ERG is usually normal, and usually they carry a very good prognosis. And this is again, I'm sure this is not a fundus flavic in between. I want to shoot this picture. This is, you can see another cystic lesion in the macula. This is very classical cystic lesion in the macula. And it's not an egg yolk, but a cystic lesion. And sometimes when you have a 70-80 examination on slit lamp, you can see some movements within the cyst. And here you can see some lesions in the cyst with a head-like appearance. And another diagnostic thing is an ultrasound. You can see a cystic lesion. And sometimes the dynamic ultrasound, you can see some movements within the cyst. And you'll have a high surface reflectivity and also a fall in internal reflectivity, and again a high internal reflectivity. This is a classic cysticercosis cyst, which affects the macula, or it can be in the choroid, or it can be in the ocular coats, or it can be extra ocular also. This is a classic cysticercosis cyst in the posterior pole. The next slide. And then nextalopia is nothing but a description of a night blindness. It can be either progressive or static, like in congenital stationary light blindness. And nextalopia can be because of nutritional deficiency, like with the vitamin A deficiency, sometimes after gastrointestinal surgery because of faulty absorption of these vitamins. And after liver disease also, nextalopia isn't reported. And chronic drug therapy like chloroquine can cause nextalopia at the later stage. Trauma can cause, and systemic abnormalities and family history also can cause nextalopia. And then coming to retinitis pigmentosa, this is also one of the commonest retinal dystrophies which you see in your clinical practice. It's a progressive hereditary retinal degeneration of the photoreceptor and RPE complex. So as the name suggests, it's a photoreceptor and later RPE complex. So ERG is very diagnostic. And there is a poor dark adaptation. Night blindness is classical. And peripheral visual field constriction and problems with the central vision at a later stage when there is a macular edema. And then usually there is a dull, lusterless retina. I'll come to the pictures later. There is arterial attenuation, bony spicule pigmentation. This is a classic triad in the textbook for postgraduates. The classic triad of RP is arterial attenuation, bony spicule pigmentation, and waxy pallor of the disc. This is a classical triad, and you can pick up carrier state with genetic counseling and macular stages when there is associated with macular edema. And here you can see a waxy pallor disc, arterial attenuation, and you can see dull fovea. And here you can see the bony spicule along the equator or along the arcades. Here again, you can see the central RP atrophy in the later stage because they present with macular edema, and later stage they may present with the RP atrophy at the macula. And usually this macular edema responds well with the oral acetazolamide or the topical acetazolamide. This one macular edema responds well with topical anhydrase inhibitors. And then the ERG, the classical ERG in RP is usually extinguished in normal, to begin with normal, or to extinguish responses based on the severity of the disease. There is reduced amplitude with the delayed B wave and implicit times. And cone rod versus rod cone, it depends. If it's a cone rod, more of the photopic responses are affected. In the rod cone, it usually starts with the scotopic, then goes to this photopic. And extinguished ERG seen in late stage. There is an average of 16 to 18% loss of ERG amplitude per year. So this ERG in RP is diagnostic as well as prognostic, and detection of carriers. It helps us to find out the carriers as well. And the visual field, classical field is a central tunnel vision at a later stage, and there is 4% visual loss per year, especially in an autosomal dominant variety. And sporadic usually have a good prognosis. Coming to Leber's congenital amaurosis, this is a spectrum. The RP and Leber's congenital amaurosis is a spectrum of the disease. Leber's congenital amaurosis usually presents at birth, early in life. As I said, when the dystrophy presents in early part of life, before 2 to 3 years, then nystagmus is an associated feature, along with reduced vision. And ocular digital sign is a classical feature of Leber's congenital amaurosis. And they can have wide variety of fundus changes, and ERG is grossly reduced or extinguished. And usually they have an hyperopic and keratoconus. This is because of the ocular digital sign constantly pressing on the lids and the cornea. And this is a Leber's epigenetic. You can see arborescent pattern in the periphery or in the equator, and the bony spicule sort of configuration. This is, or sometimes they call it as a crocodile sheen on the retina, which is a classical description in a Leber's congenital amaurosis. And then there is another variety called childhood onset RP. Normal, they have a normal vision in infancy. This is different from the congenital amaurosis. And there is absence of nystagmus in infancy. And usually they will not have nystagmus, and good visual function in infancy. And the age of onset is between 3 to 10 years of age. And because of the childhood onset, there is a rapid visual loss over the teens and the second decade or third decade. And you should rule out neuronal ceroid lipofuscinosis. This is one differential diagnosis for childhood onset. Then atypical RP, this is retinitis punctata albicans. There is another variety is albipunctatus. This punctata albicans is a progressive disease, whereas albipunctatus is a non-progressive variety of a congenital stationary light blindness. One thing which I keep it in mind when I was doing my post-graduation is punctata P starts, so it's a progressive. So it's always confused between a punctata albicans and albipunctatus. So punctata, since the P is in front, is a progressive variety, whereas an albipunctatus is a non-progressive. And sometimes you can have a sectoral RP, or you can have a PPCRA, that's pigmented paravenous chorioretinal atrophy. Sometimes you can have pericentral, and sometimes exudative, and very rarely you can have unilateral. You can see along the vasculature, this is PPCRA, and sometimes the RP is in the center. Usually RP is in the equator and anterior to that, but you can have a central RP also. This is a diffuse RP central, and sometimes it can be unilateral as well. And RP is usually associated with various syndromes like Bayesian conflict, which is A-beta lipoproteinemia. Sometimes they can be associated with the Refsum syndrome. And Usher syndrome. Usher syndrome is of interest because there is a lot of the sensory neural deafness, and it's part of the Tamil Nadu government that any sensory neural deafness which goes for the implants, the cochlear implant, they need to have the eye screened to rule out the Usher syndrome, and they do have the kidney renal abnormalities as well. And then we have Lawrence-Moon-Biddle syndrome. They are associated with the neurological deficits. And Barrett-Biddle will have polydactyly, renal disease, obesity, and then also hormonal disturbances. And then cocaine, which is premature aging and deafness. Kane's hair, which have a microcordial cytopathy. They have cardiac abnormalities and ragged red fiber. These are part of the MCQ questions for the postgraduates. And mucopolysaccharidosis, which have a corneal clouding because of the deposits in the cornea. And then for completion, we have hereditary retinal degeneration like Stickler syndrome, Wagner syndrome, and Goldman-Fabry, where they also can have macular pathologies. And then choroideremia, the choroidal degeneration, is an excellent recessive, usually affects young males, and females are usually the carriers. Onset of age is between 8 to 18 years, and they have night blindness, good visual acuity. Early stage may have non-specific granular appearance and normal disc and retinal vessels. So that's a difference here. You can see the retinal vessels are normal and disc is normal. You can see extensive choroidal atrophy. And then ERG is usually subnormal. They have delayed dark adaptations. And for carrier, there's mid-peripheral pigment alterations will be seen. That's usually the females. And the other one is gyrate atrophy, which can be treated with nutrition. This is because of the deficiency of oxaloaminotransaminase, and is usually associated with hyperornithemia. This enzyme helps in digestion of this ornithine, and it comes in the process of the ornithine metabolism. And it associated with the nyctalopia, and usually they have axial myopia, usually poor peripheral vision. You can see over this picture. And ERG is usually subnormal, and pyridoxine supplement is helpful in treating the disease. Coming to the CSMB, they can have either with a normal fundus or abnormal fundus. In a normal fundus, you'll have negative waveform on ERG or reduced or non-recordable scotopic responses. And abnormal fundus, you have Oguchi's disease and fundus albipunctatus, which is a non-progressive. So you can see with the normal fundus, everything looks normal, but the patient complains of a night vision deficiency. When you do an ERG, you can see the flat scotopic responses and combined negative responses over here. And the photopic later stage may be affected. And then albipunctatus, which I said, this is a non-progressive variety, and the differential diagnosis for the RP as well. Normal visual acuity, they have normal visual field. They don't have visual field defect like an RP. And they have a good visual acuity, and it's a non-progressive variety of CSMB. And then this is, you can see a lot of white lesions across the fundus. So that is fundus albipunctatus, non-progressive. And Noguchi's disease, they have delayed dark adaptation. One important thing is the mesophenomena. What is mesophenomena is they have an abnormal golden yellow sheen, and when you dark adapt for 45 minutes, you'll see a normal retina. So this is Oguchi's phenomena, and that is with Oguchi's disease, non-progressive. And then we have foveal hypoplasia. It is usually associated with albinism, and they have, because they present the early part of life, they'll have nystagmus and subnormal vision. And all of the fundal macular dystrophies, you need to have fundus photograph to document the progression, clinical progression. Then you have an FFA, and then you have color vision, visual fields, ERG and EOG. As I said, retinal dystrophies, ERG is mandatory. When you have a RP dystrophies, EOG is mandatory. And then dark adaptation studies. And management, because you have to have prompt diagnosis, because certain retinal dystrophies can be treated with dietary modifications. So diagnosis is very important. And you have to discuss the therapeutic options to the patients, because most of the dystrophies, we don't have a treatment. So there has to be detailed discussion and counseling with the patients as well as the parents. And then genetic consultation to find out what is the real problem. And some RP at the moment have some gene therapy as well. So these are therapeutic options. As I said, appropriate refractive correction, because most of them have a hyperopic and some has a myopic error. So refractive correction, to some extent, it will help in restoring the vision. And cataract is usually one of the complications in retinitis pigmentosa. As I keep telling my RP patients, we cannot treat the disease, but we can treat the complications of the disease like early cataracts and early macular edemas. These can be treated. And low vision aid is definitely an important treatment tool when you treat macular dystrophies. And vitamin and nutrition supplementation, like you see in gyrate atrophy, and vocational and educational rehabilitation is mandatory for these patients. So that's about it. And this is another macular problem, and most of us seen in middle age it's very common in men between 40 to 50 years. And you can see a classical smokestack appearance over here, and then an umbrella type of leakage, which is a classical CSR, what we call central serous retinopathy. This comes under the vascular choroidal problems. And you can see a smokestack appearance over here. And another macular problem is a myopic maculopathy, which is very common. And one classic OCT picture, you can see the OCT itself is convex. And this is classical myopic maculopathies. You can see the macular schisis over here, and it's neurosensory. This is not a classical neurosensory detachment, but this is a schisis of the macula. And the classic OCT, it's like this, a bowing of the macula is very common, or a choroidal bow, what we call, is very common in a myopic maculopathy. And then this, I'm not going into the depth of it. My previous speaker, Dr. Hasan, has spoken about this. And you can see one classic thing which I want to tell the postgraduates over here is, you see a lot of, the hard X-ray is a classical hallmark of a diabetic maculopathy or a diabetic retinopathy because of the leaky vessels. Whereas if you see a lot of cotton wool spots, you can see a lot of cotton wool spots. So this is a mixed retinopathy. This is not a pure diabetic maculopathy. This is a mixed retinopathy. You can see hard X-rays and a lot of cotton wool spots. So hard X-rays is a hallmark of a diabetic maculopathy or diabetic retinopathy. And this is one classical picture. You can see a lot of cotton wool spots, and you can see the media haze. And this patient's hemoglobin was 8 grams and fasting was 280, means its sugar is not under control. Serum creatinine is high. So this patient has all the comorbid conditions. You should not jump into, because the current treatment for any center involving macular edema is intravitreal injections. You should not immediately jump into treatment. So systemic workup is important, and systemic treatment is very important when you treat with diabetic maculopathies. And this patient was referred to diabetologist, hematologist, and review after a month. You can see with the systemic control and every parameter is taken care. He had a blood transfusion, he had treatment for his sugars, everything. You can see even without any treatment, the OCT is becoming normal, and you can see the media is also improving. So it doesn't mean anti-VEGF injection, because anti-VEGF injection has become a right, left, and center treatment for macular edemas. So systemic control is very important. This message I want to drive to all the postgraduates. And you can see when the patient presented and with the patient with the systemic management alone, how he has improved. So this is the OCT picture. And the other surgical pathologies involving the macula, you can see an ERM over here. This should not be treated with intravitreal injection, and you can see a classic vitreomacular traction. And this is again a macular hole. I'm not going into the details of it. The various stages of macular hole, the test groups will give you. There's another surgically treatable or a macular pathology or an acquired because of trauma. So I think that's with my macular pathologies. Thanks for giving an opportunity, and thanks for the patiently listening.
Thank you so much, sir. That was a very elaborate talk in such a short time. And thank you for covering all the dystrophies. And those are some wonderful pictures and textbook pictures, which I think our PGs would benefit, spot diagnosis types. So thank you so much, sir. And I'd like to, if there are any questions, we'll take them on our chat box. Thank you again, sir, for sparing your time. I'd like to call upon our next speaker, Dr. Ramesh Venkatesh, to discuss on vascular disorders. So Dr. Ramesh is another product from the prestigious Shankar Nethralaya, did his fellowship in VR from there. And he was working with Dr. Schroff's Charity Eye Hospital until 2017. He has a keen interest in academics and research. And his areas of interest include management of retinal vascular disorders like diabetic retinopathy and vascular occlusions, ARMD. And who better than him to talk about vascular disorders today? I'd like to welcome Dr. Ramesh.
Yeah, thank you, Dr. Preeti. Am I audible and is my screen visible?
Yes, sir. Both you're audible and your screen is visible. Thank you.
So first of all, I want to thank the team Agarwal for giving me this opportunity, and it's a pleasure always talking about something which you like to do to the postgraduates. The way I'm going to talk about my subject is because it's a very vast subject and 15 minutes is not going to be sufficient enough. So I'm going to make basically some concept-driven things so that the postgraduates are able to understand more lucidly what we are going to talk about. So when you look at the retinal vasculature or the retinal vessel or any vessel itself, it is basically consisting of a lumen and a vessel wall. And the vessel wall is basically lined by three things. One is the endothelium, the pericytes, and the basement membrane. Now, whenever you have a vascular disease which is affecting the retinal vessels, you can have problems which are involving the lumen of the vessel, or it can be secondary to the vessel wall itself. So these are these are the things which we really need to look at. So whether the pathology involving the retinal vasculature, is it involving the lumen of the vessel, or whether as you get in occlusions or emboli, where you have a fibrinoplatelet emboli, cholesterol emboli, or even because of the rouleau formation or the slowing of the blood flow, you can have luminal occlusions which can happen, and the vessel wall changes which can happen with arteriosclerosis, as in hypertension, or in patients with vasculitis secondary to inflammation. So there is where you need to understand that the vessel wall can get involved. So there are the two parts of the vessel which can get affected. So basically, when you look at the pathogenesis of retinal vascular diseases, you have occlusive diseases, which can be, there are occlusive diseases, there can be inflammatory diseases, there can be infections which can affect the retinal vessels, and you can have tumors, okay, which can affect the retinal vasculature. So when you look at the causes, or when you look at the broad understanding of these pathogenesis or the occlusion, so you have diseases which are the central retinal artery occlusion and the branch retinal artery occlusion, the central retinal vein and the branch retinal vein occlusion, and even when you have capillary diseases like the diabetic retinopathy, macular telangiectasias, and blood dyscrasis, as in cases of anemia, thrombocytopenia, and chronic myeloid leukemias, where you can have these occlusive changes which are affecting the lumen of the disease, lumen of the vessel. You have inflammatory diseases which causes inflammation to the retinal vessel wall, as in cases of idiopathic retinal vasculitis, tuberculosis vasculitis, and even in Behçet's disease. And you have infections, basically the CMV retinitis, which presents to you with multiple hemorrhages over the posterior pole. That is what is very classical of CMV retinitis. And tumors like the vasoproliferative tumors of the retina, that is what is classically being described as the VPTR, the angiomas are being described in the tumor. So this is what your broad classification on the basis of pathogenesis is. Now let's understand what the vascular anatomy of the how does the vascular circulation happen in the retinal vessels. So you have the blood which is coming through the central retinal artery, then it fills up into the retinal arterioles, and then the blood from the arterioles, they go into the capillaries, and these blood in the capillaries are drained eventually by the smaller venules, and they fill into the retinal vein, and then they go in from a direction from the periphery towards the center, towards the optic disc, through the central retinal vein. So you can see this very clearly, that you have a central retinal artery, you have an arteriole, you have a capillary, and then the blood from the capillary draining into the venule and eventually into the central retinal vein. So when you look at the diseases which are involving primarily the artery, you can have occlusive diseases like the central retinal artery occlusion and the branch retinal artery occlusion, or you can have aneurysmal lesions like involving the vessel wall, where there is outpouching of the vessel, outpouching from the arterial vessel wall, leading to artery macroaneurysms or the retinal artery macroaneurysm. In the arteriole, you can have the occlusive diseases, which we call as a paracentral middle maculopathy or acute middle maculopathy, and you have the acute macular neuroretinopathy, which are occlusive diseases which are involving the retinal arteriole. You have capillary diseases, which is predominantly going to be the diabetic retinopathy, hypertensive retinopathy, macular telangiectasias, both the aneurysmal variety as well as the exudative variety. You have the capillary macroaneurysm, the PEVAC or the perifoveal exudative vascular anomalous complex. You have the retinal angiomatosis proliferans, where you have a neovascularization starting from the retinal capillaries. You have retinal neovascularizations or the retinal NVEs, and you can even have tributary vein occlusions, where there is a blockage of the capillaries which is draining into the smaller venules. Now, when you look at diseases which are affecting the venules itself, that is where you will have the macular retinal vein occlusions, and where you have a larger retinal vein which is going to get affected, that is the central retinal vein. You can have central retinal vein occlusion or a branch of the central retinal vein, which is known as a branch retinal vein occlusion. And inflammatory diseases which can affect the retinal vein is where you have the vasculitic disorders due to tuberculosis and Behçet's disease. Now, what you need to understand is there are very classical features where you have an artery occlusion versus a vein occlusion, and that is something which you need to understand. Now, this is a case of a central retinal artery occlusion with coeloretinal sparing. So what you can see in the central retinal artery occlusion is you can see that there is opacification of, there is opacification of the retina. You can see that there is retinal opacification. And the reason why you get this retinal opacification is because of the extracellular edema which happens. And that is because of the acute infarction to the retina which causes the fluid and the fluid to come out from the cellular structures into the extracellular space, leading to the opacification. Now, because of this opacification and because the central retinal artery is basically supplying the inner 6 layers of the retina and the outer retinal layers are spared, what you get is a classical appearance or the sparing of the fovea, which is seen as the presence of a cherry red spot. So what you get here is a cherry red spot, which you get in a classical case of central retinal artery occlusion. Now, sometimes you can have a cilioretinal artery which is present. You can see this very nicely that this is a cilioretinal artery which is arising in a hook-shaped fashion from the margin of the optic disc, which can supply right till the macula and then preserve the vision. So it is basically maintaining the macular perfusion and trying to preserve the vision as well, because it is maintaining the perfusion of the papillomacular bundle. And therefore, the presence of a cilioretinal artery, which is patent, it is helping into maintaining the perfusion of the papillomacular bundle, and therefore patients with cilioretinal artery occlusions can have good visual acuity as well. Now, on the other hand, what you can see is that this is an area where there is retinal opacification which is present, which is predominantly involving the area which is being supplied by the cilioretinal artery, and therefore this is a case of a cilioretinal artery occlusion, and whereas the central retinal artery is totally being spared in this case. Now let's look at what happens in venous occlusion. So when there is venous occlusion, so because the veins, they are going to drain into the central retinal vein, now towards the optic disc from the periphery. So the minute there is an occlusion at the optic disc in the central retinal vein, there are going to be backflow changes which are going to happen in the vein, leading to luminal changes, luminal increase in the luminal pressure changes, and leading to the blood to spill out from the retinal vasculature into the extravascular space. And therefore, the first thing which you get when there is an occlusion of the central retinal vein is the dilatation and the tortuosity of the retinal veins, following which you have the leakage of the hemorrhages in all the 4 quadrants. That is what is being classically described as the flame-shaped hemorrhage and the dot and the blot hemorrhages, which is seen in a central retinal vein occlusion. Now let's look at what happens in a branch retinal vein occlusion. So the branch retinal vein occlusion is where there is the occlusion is happening at the site of AV crossing changes, and at the proximal portion of the vein, that is at the proximal portion of the vein, there is a stasis of the blood which leads to the spillage of the blood from the vessels into the outer space, leading to the classical appearance of the flame-shaped hemorrhages at the site of occlusion. And as you go towards the periphery, you get more of these blot hemorrhages, which is suggestive that there is a capillary changes as well. That means the luminal changes are happening in the capillaries, and therefore you have more of the blot hemorrhages which are being seen as you go distal or towards the retinal periphery in a case of a branch retinal vein occlusion. So when you look at the comparison between a vein occlusion versus an arterial occlusion, the most characteristic feature is that there is absence of hemorrhages in an arterial occlusion, and similarly, there is absence of retinal opacification or infarction which is happening in a vein occlusion. This is the most important and characteristic difference which you have to note in a patient with an artery occlusion versus a venous occlusion. Now let's look at the other diseases which is involving the retinal artery. So in this patient, you can see that there is a succinate hard exudate which is involving the inferior-temporal arcade. And when you do the fluorescein angiography, you can very well identify that there is a presence of an aneurysmal lesion which is arising from the first order branch of the retinal inferior-temporal branch of the central retinal artery. The ICG is also able to identify these aneurysmal lesions. They are polyp-like lesions, or they are elevated lesions which is seen along the inferior-temporal artery. And you can have retinal aneurysms or macroaneurysms even in inflammatory condition which is called as the IRWAN. So what is the IRWAN? IRWAN is basically, it is an acronym which is being for idiopathic retinal vasculitis, aneurysms, and neuroretinitis. So in this case, you can see that there is neuroretinitis where you have a macular hard exudates. You can have vascular leakage because of the retinal vasculitis, and here you can very classically see the presence of the multiple aneurysms which are involving the retinal artery. So these circular lesions which I'm annotating right now, these are the aneurysmal lesions which are seen in a case of IRWAN lesion. Now let's look at the capillary diseases which are involving the eye, the capillary vascular diseases. And the most important and the most common out of them is the presence of diabetic retinopathy, where the initial sign is the presence of multiple microaneurysms. And when these microaneurysms, they start leaking, they will lead to the accumulation of the succinate hard exudates. So like what Dr. Kashi said is that the presence of the hard exudates is an indication that there has been an insult to the retina because of the diabetic maculopathy. Now, there are reasons why the diabetic retinopathy can lead to vision loss, and most common reasons where you have mild to moderate vision loss is because of the macular edema, and severe vision loss happening because of the macular TRD or macular tractional detachment and the vitreous hemorrhage, and even in cases secondary to macular ischemia. Now, you can have capillary lesions where you have the aneurysmal size much larger than what you get in a microaneurysm, and that is what is called as a large microaneurysm, which is seen in a Pevak-like lesion on what you call as the perifoveal exudative vascular anomalous complex, where you have an aneurysmal dilatation which is arising from the deep capillary plexus, which is leading to extensive exudation. You can see these extensive hard exudation and surrounding macular edema as well. Now, let's look at other diseases which can involve the capillaries at the macular lesion. These are the cases of type 1 macular telangiectasia, again an aneurysmal lesion which is involving the macular area. Then let's look at the another macular lesion which can, or peripheral telangiectasias, which can lead to leakage and extensive hard exudation. And this is what is called as the Coats disease. The Coats disease is basically a pediatric disease which is seen in the 6th to the 10 years of life, where you have extensive peripheral telangiectasias, which is leading to leakage and hard exudation. But you can also have Coats disease or a Coats-like response happening at the posterior pole, where you have the classical light bulb appearance on the fluorescent angiography, and you can identify these aneurysmal lesions, which are then surrounded by succinate hard exudates as well. Now, the other lesion which is present is the most common is the exudative variety of the type 2 macular telangiectasia, which is usually a bilateral disease seen in the 5 to 7 decades of life and characterized by the 5 stages which have been described by Gass and Blody. And this is a case where you have the type or the stage 4 disease, where you have the pigment plaque and the perifoveal graying, which is seen in the macular region. The other lesions which can be seen in the periphery, or another tumorous lesions which can be seen in the periphery, or the vascular lesions where you have these peripheral hard exudation and leakage. And when you look at this FFA, this is not a case of a neovascularization which is happening at the ora serrata, but this, when you look at these lesions on the OCD, you can see that this is where the lesion is now protruding into the vitreous cavity, and therefore this is a proliferative lesion which is arising from the retinal vasculature, and therefore this is called as the VPTR, or what you call as the vasoproliferative lesions, or the vasoproliferative tumor of the retina. Now let's look at a few of the pediatric retinal vascular diseases which are of utmost importance. Let's look at the retinopathy of prematurity seen in patients with low birth weight, usually less than 1.5 kilograms birth weight, or gestational age less than 28 weeks, where you have divided into 5 stages. The first stage is the presence of the demarcation line, where you can see that this is the vascular retina, this is the vascular retina, and this is the avascular retina which is seen, and that is the demarcation line. When this demarcation line becomes more thicker and has a 3 dimensions to it, then it is then called as the ridge. Then when you have the neovascularization which is protruding into the extraretinal space, then it is known as the stage 3 disease, where you have the extraretinal proliferations which are happening. And then you have the stage 4, which is called as the subtotal retinal detachment, which is seen with the ROP, again further divided into 4A and 4B, whether the fovea is involved or not. And then the stage 5 disease, which is called as the complete. This is the stage 5 ROP, which is known as the total detachment of the retina in cases of stage 5 disease. Now, another disease, vascular disease, which is of importance, which is quite similar to the retinopathy of prematurity, is the presence of familial exudative vitreoretinopathy, where you can see that there is basically the mild, moderate, and severe forms. It's a bilateral disease where you have the mild, moderate, and severe forms, and these stages are basically following the pattern of retinopathy of prematurity, and eventually you can see what is being classically described as the falciform fold, which you get in a case of a retino, or in a case of FEVR, which is because of the fovea getting, or the retina getting pulled up in that area. So when you look at most of these retinal vascular diseases which I have described so far, there is a lot of commonality to these vascular diseases. The commonality is that you have retinal opacification in almost all the cases of arterial occlusive diseases. When there is an artery involvement or the arterial involvement, you have retinal opacification. Whereas when there is a capillary involvement or when there is venous involvement, then you will have patients presenting with hemorrhages, hard exudation, and leakage of the fluid from the intravascular to the subvascular, extravascular space, leading to the accumulation of the fluid in the intraretinal space or in the subretinal space. These are the commonalities. You don't need to mug up what are the features or what are the diagnoses, what are the symptoms or signs which you get in vascular diseases. These are the only 4 signs and symptoms which you get in vascular diseases. Now, when you look at the management is going to be first to identify what is the mechanism of the vascular disease, whether it's an occlusive variety, whether it's an inflammatory variety, infective variety, or whether it's a tumorous lesion. That is what you need to understand. That is where it's important to identify the mechanism of the vascular disease, then identify if the disease or the disease activity is involving the macula. That means when I say disease activity, we are trying to say whether there is presence of intraretinal or subretinal fluid which is involving the macula, or whether the disease itself is a macular pathology. Check for the peripheral involvement, like what you see in cases of Coats disease, in cases of FEVR and retinopathy of prematurity, where you want to look for the peripheral involvement, and then look for the complications because of the disease itself, where you can have capillary dropouts, which is leading to neovascularization of the retina, and that is very important. So when you look at the treatment is basically directed towards the cause. So if you have a patient of a vascular disease which is secondary to an anemia or a thrombocytopenia, you basically need to treat the anemia and the thrombocytopenia, and the vessel wall integrity is maintained. If there is a macular edema which is involving the central area, then treatment is usually with intravitreal agents such as anti-VEGFs and intraocular steroids. Focal laser can be done basically for aneurysmal lesions which is involving either the periphery, as in cases of Coats disease, or in cases of macula, such as in cases of type 1 MACTEL, PAVAC-like lesions, or in patients with microaneurysms, as you get in diabetic retinopathy. Panretinal photocoagulation, that is to be done in the presence of retinal neovascularization with capillary dropout, and systemic steroids and immunosuppression is required in inflammatory diseases like Behçet's disease, like retinal vasculitis and tuberculosis. So thank you so much for giving me this opportunity. I want to thank the Agarwal team again for giving me this opportunity. And I hope I have made this presentation, a big presentation, in a short and a concise manner, lucidly to all the postgraduates who are sitting here. Thank you very much.
Thank you so much, sir. I mean, you made such an elaborate topic so simple, and the marker that you were using really helped to draw their attention to what was important, and it probably helped them understand better. Thank you very much.
Yeah, thank you, Vaishnavi. Thank you so much.
So our next speaker.
There's a question in the chat.
Oh, okay.
So there is a reversal of flow in FFA seen in only blockage conditions. Yes, so reversal of the flow in FA conditions, Dr. Ashit, is primarily seen with vascular occlusions, basically arterial occlusions, where you have some amount of vasculature should be present. Then only the blood supply from the other quadrant can flow back in a reverse direction into the affected quadrant. So that is something which we have noticed with branch retinal artery occlusions or hemicentral artery occlusions, or even when patients with central retinal artery occlusions where the cilioretinal artery needs to be spared. So these are the conditions where you can have a reversal of the flow of the dye on fluorescein angiography.
Thank you so much, sir. Are there any other questions? I don't think so. Okay. So we'll move on to the next speaker. I welcome Dr. Santosh Honavar. He's no stranger to Kalpavriksha. We've had him speak here before. He's the Director of Medical Services at Center for Sight. He's specialized in oculoplasty, facial aesthetics, and ocular oncology. He has been extensively published in peer-reviewed journals and has written several book chapters. There's no end to the number of accolades and awards that he has accumulated over the years. We welcome you, sir, once again.
Thank you so much. I'll speak on retinoblastoma first and then on intraocular tumors. And it's a pleasure to be part of Kalpa over several years, I should say. So I'll be speaking about retinoblastoma, which I think is important for postgraduate examination in terms of theory as well as OSCE and spotters. Retinoblastoma is the most common intraocular malignancy in children, no doubt. It's a deadly tumor with potential for up to 50% mortality if it is not properly treated or if treatment is delayed. And patients mostly present to an ophthalmologist or a pediatrician first. And most important, it is completely curable if it is detected early. This slide shows the evolution in the prognosis of retinoblastoma. Just about 120 years ago, we had 98% mortality. And there's a total turnaround in 2020, we have 98% survival, which hasn't happened for any other malignancy. This is the world retinoblastoma map. India is in dark blue, mainly because of its higher birth rate. And consequently, about 20% of retinoblastomas in the world present in India. The number is estimated to be about 1,500 to 2,000 new cases every year in India. Now, clinical manifestations are very straightforward. Leukocoria happens to be the most important symptom and sign as well. Depending on which country, you may have leukocoria ranging from 30 to 70%, but roughly about 40 to 60% of patients present with leukocoria as the symptom. That's what the parents tell you. And as a sign, when you look at them, they will have leukocoria. And children being children, they get easily adapted to seeing with one eye, and they simply don't express any symptoms at all unless it's a bilateral disease. Squint is also quite common. It's seen in about 20 to 30% of children. It could be either esotropia or exotropia, depending on the age of onset and the location of the tumor. Redness of the eye is a rare symptom. It is seen in patients who have secondary manifestations such as neovascular glaucoma, as you see here, secondary cataract, as you see here. When the eye is completely filled with tumor, then there would be some inflammation because of necrosis, and that results in congestion. This is orbital retinoblastoma. Fortunately, it's become very rare. Now, the most important diagnostic tool for retinoblastoma is indirect ophthalmoscopy, no doubt at all. The diagnosis is mainly by indirect ophthalmoscopy, direct visualization of the tumor under examination in anesthesia. Ultrasound B scan helps you measure the size of the tumor and also confirm if there is any intraocular calcification. In a situation where there is total retinal detachment, when you may not be able to see through that detached retina, it will help you see the tumor which may be lying under the retina. That is the role of ultrasound B scan. Whereas CT scan is not really indicated in retinoblastoma in majority of situations unless you want to know whether there is intraocular calcification or not. Whereas MRI is definitely indicated for many reasons. One is that if you have a patient with heritable retinoblastoma, unilateral multifocal tumor or bilateral tumor, or with family history of retinoblastoma, you want to know whether there is pinealoblastoma or not. So that is one indication for MRI. MRI is also necessary if you want to know whether there is optic nerve extension, choroidal invasion, ciliary body invasion, or extraocular extension, which you may not be able to clinically see. So MRI does have a role in group E retinoblastoma and also in heritable retinoblastoma. Most common differential diagnosis for retinoblastoma are Coats disease, PHPV, toxocariasis, astrocytic hamartoma, and medulloepithelioma. In Coats disease, unlike what is seen in retinoblastoma, it's called leukocoria, whitish pale yellow reflex. In Coats disease, you see xanthocoria, that is golden yellow or yellow reflex, deep yellow reflex, mainly because of the exudation. And you see very dramatic appearance of peripheral retinal telangiectasia, intra and subretinal exudation. And in persistent hyperplastic primary vitreous, you see relative microphthalmos. It may not fit into the definition of microphthalmos, but you see a smaller cornea, smaller eye on the affected side. And there are also prominent ciliary processes and of course cataract. And when you do ultrasound B scan, you find that there is a fibrovascular proliferation that is arising from the disc going towards the posterior pole of the lens. Now in toxocariasis, there are two variants. One is the peripheral variant, where there would be a falciform fold. It is a lesion with intraocular calcification or intralesional calcification, whereas the central toxocariasis would have bragg disc appearance. In retinal astrocytic hamartoma seen in tuberous sclerosis, etc., you find that there are two variants. One is non-calcified, which obscures the blood vessels. It's like a button sitting on the retina, whereas the calcified lesion has multiple sperules of calcification. It's like conglomeration of fish egg. Medulloepithelioma is a tumor which is of embryonal origin, so consequently zonules don't form in the involved sector of the ciliary body. So you see this is the medulloepithelioma and this is the zonular coloboma, because of which lens appears luxated. Coming on to classification of retinoblastoma, in any malignancy there are two ways of classifying. One is grouping, where the organ salvage is prognosticated, and staging, when live salvage is prognosticated. In retinoblastoma, we have international grouping of intraocular retinoblastoma, which is a simple classification where group A would mean that tumor is less than 3 mm in diameter. Group B for bigger tumors, more than 3 mm in diameter, macular location, or tumors with subretinal fluid. C is for confined or contained subretinal seeds, as you see in exophytic retinoblastoma, or contained vitreous seeds, as you see in endophytic retinoblastoma. Just remember D as diffuse subretinal seeds, and diffuse vitreous seeds. E are potentially enucleable eyes, where the tumor is filling more than 50% of the vitreous volume with neovascular glaucoma, hyphema, vitreous hemorrhage, etc. That is the international grouping of intraocular retinoblastoma. Now, international staging is something you may not want to remember, but you should simply remember that there is a staging system which prognosticates life. Stage 0 is when the eye has been conservatively managed, no enucleation. Stage 1, when the tumor has been completely resected by enucleation. Stage 2, enucleation has been done, but there is microscopic residual tumor, which brings the pathologist into perspective. They have to tell us whether there is microscopic residual tumor or not. Stage 3 is orbital disease or regional lymph node extension. Up to stage 3, there is good prognosis, up to 95% survival. But beyond that, this is the watershed zone between stage 3 and 4. There is sudden drop in survival, and it is less than 5%. This is the new international classification of retinoblastoma. This is AJCC classification, AJCC 8, TNM, tumor node metastasis classification. What is new, you might be asked sometimes, is the alphabet H has been added to TNM for the first time for any malignancy. H is for heritability or genetics, bringing genetics into a very sharp focus in diagnosis, screening, and management of retinoblastoma. Coming to management, 3 goals of managing retinoblastomas are to save lives, save the organ, and to salvage residual function, that is optimal residual vision. There are many ways of managing retinoblastoma. I'll very quickly enumerate these. If there is a small tumor, which is say group A tumor or even B tumor, when you're sure that there is no risk for life or the eye salvage is almost guaranteed, then you aim at vision salvage. Cryotherapy is one good way of doing it. It's called triple freeze-thaw cryotherapy, where the tumor is frozen thrice and is allowed to spontaneously thaw thrice. It has good success, but the scar that is produced by cryotherapy is much larger than the tumor, so it may have some visual consequences. Photocoagulation was used earlier, where you actually surround the tumor with 2 rows of large diameter laser buns, but that results in a much larger scar and also vascular occlusion. So the current standard of care for focal therapy is transpupillary thermotherapy. This is the way transpupillary thermotherapy is done. It is done on top of the tumor, so the scar that is produced is never going to be larger than the tumor that you began with, and the blood vessels that pass through the area are classically patent. So TTT is the standard of care for focal therapy. In chemotherapy, which has of course been the standard of care for the last 20 odd years, we have intravenous chemotherapy. Standard dose intravenous chemotherapy is how we began in 1996. Now we have all other forms of chemotherapy, including intraarterial, periocular, and intraocular. Intravenous chemotherapy is delivered by 3 drugs: carboplatin, etoposide, and vincristine. You may want to simply remember the names of these drugs. It's called VCE protocol: vincristine, carboplatin, and etoposide, not the dose. It's given 6 times, 6 cycles every 3 to 4 weekly. You perform examination and anesthesia before each cycle. It reduces the tumor to the extent that the scar that is produced is much smaller than the tumor that you began with, thus freeing macular fovea very early in the course of treatment, thus maximizing vision. It also acts by the way that the tumor regresses towards its source of blood supply. Here the supratemporal blood vessel is the source of blood supply. You can see that the tumor regressing towards it, thus freeing fovea macula very early in the course of treatment, again maximizing vision. It also reduces subretinal fluid very rapidly, thus again maximizing vision. If somebody asks you what is the standard of care for advanced retinoblastoma in India, group C, D, E, then the answer would be still intravenous chemotherapy, because that is what we do in about 85 to 90% of patients, not because we don't have intraarterial chemotherapy available, but because it's expensive. Now, what is the standard of care in the West for advanced retinoblastoma? CDE, it is superselective ophthalmic artery intraarterial chemotherapy, also called as chemosurgery. Now, the way we deliver it is that the interventional neuroradiologist gets us access to the ophthalmic artery using a 400 micron catheter. Then we take over and inject 1 to 3 drugs. The standard drug is melphalan. If one drug is used, that's always melphalan. But if you want to use more than one drug so that the effect is much quicker and you can use fewer cycles, then that would be topotecan and carboplatin. So melphalan is the drug you might want to remember for the purpose of MCQs. It reduces SRF very quickly, and also tumor regression happens very rapidly. So it's more quickly it works very, very quickly and very effectively, and at least has about 5 to 10% additional chance of eye salvage over intravenous chemotherapy. It also works for recurrences. Now, this is the regression pattern of retinoblastoma. You're often asked in the exam, what is the regression pattern in retinoblastoma? Type 0 is when the tumor completely disappears, leaving no retinal scar. That is possible in smaller tumors. Type 1 is complete calcification. It is called cottage cheese appearance. Calcification is seen in endophytic retinoblastoma, more commonly than exophytic. Type 2 is when there is completely non-calcified residual scar. This happens in well-differentiated tumors. Type 3, when there is a partially calcified mass, that means bit of fish flesh and bit of cottage cheese. And type 4, when there is a flat atrophic scar. Now, what about retinoblastoma seeds? We don't call them vitreous seeds anymore. We call them intraocular seeds, because we have a variety of seeds now. Classic vitreous seeds, as we already knew them. Then we have prehyaloid, subhyaloid, epiretinal, intraretinal, and subretinal based on OCT. And intracameral can be depository, which come through the zonules and get deposited in the anterior chamber. And infiltrative, those come through infiltration of the ciliary body, peripheral iris, and the trabecular meshwork. Morphologic classification of vitreous seeds in the form of the way they look, appear: dust, cloud, spear, and mixed pattern. Now, how do you treat vitreous seeds? You treat vitreous seeds currently by using intravitreal chemotherapy. Intravitreal chemotherapy began with melphalan, which is the same drug that is used in intraarterial chemotherapy. But in pigmented eyes, melphalan causes several complications, including retinal pigment epithelial atrophy, cataract, and uveitis. So in India and pigmented races, the drug of choice happens to be topotecan. Topotecan is a much gentler drug, given 30 microgram every 3 weekly. And you can see nice effect of topotecan here. Vitreous seeds regressed. Similar situation here, similar situation here. And sometimes they get completely calcified. What do we do for anterior chamber seeds? We inject topotecan in the anterior chamber. That's called intracameral chemotherapy. And for epiretinal seeds, again, we give intravitreal chemotherapy. Now, what about enucleation? Is it still used? Of course, it is still used, but the chance of having to enucleate primarily has reduced dramatically. It is still the treatment of choice for advanced unilateral retinoblastoma, where there is no chance of vision salvage, retinoblastoma with neovascular glaucoma, anterior segment infiltration, etc. What we really need to do during enucleation is to get a long optic nerve stump and also ensure that child gets the cosmesis that the child deserves by using a primary implant and a custom ocular prosthesis. Technique, of course, is important, but what is more important than the technique is the fact that you have to subject the eye to a good histopathology to elicit what are called histopathological risk factors. In India, the chance of an eye having histopathological risk factors is as high as 50%. And if somebody asks you what are these histopathological risk factors, that is iris and angle infiltration, ciliary body invasion, major choroidal invasion defined as more than 3 millimeter in diameter and 3 millimeter in thickness, and optic nerve invasion beyond the lamina cribrosa. In all patients with histopathological risk factors, we are supposed to use adjuvant therapy. And in those who have transection of the optic nerve involvement or full thickness scleral invasion, then we use additional radiotherapy again. So this actually helps in improving life salvage. 24% is the life salvage, I mean the chance of mortality if you don't give adjuvant chemotherapy, whereas it reduces to 4% if you provide adjuvant therapy. So you can save about 20% more children just by resorting to adjuvant therapy. About orbital retinoblastoma, there's a classification again. which is primary when the tumor presents in the orbit without prior treatment, secondary following enucleation there is a recurrence, accidental when somebody does an intraocular surgery on unsuspected retinoblastoma, overt when it is missed clinically and radiologically but you see it on enucleation, and microscopic when the pathologist tells you that there is a microscopic residual on an enucleated eye. Primary orbital retinoblastoma can be clinically diagnosed or radiologically diagnosed. Sometimes a tumor like this, very subtle in the orbit, can be picked up only on an MRI. This is secondary orbital RB. This is when somebody has done an intraocular surgery on a child with RB, child manifested with extraocular retinoblastoma that is accidental. That is overt when you noticed a scleral nodule on enucleation, which was missed clinically, obviously you could not see it, and also on MRI scan. Microscopic when the pathologist confirms that there is extrascleral extension or optic nerve invasion to transection. In all these patients, earlier we would do orbital excimeration. Now the standard of care for orbital retinoblastoma is multimodal treatment. With neoadjuvant chemotherapy, you get rid of this orbital component, eye goes into a comfortable phthisis. When you do an enucleation with a long optic nerve stump, deliver stereotactic radiation and give adjuvant therapy. So combination of neoadjuvant chemotherapy, surgery, stereotactic radiation, and adjuvant chemotherapy is called multimodal treatment in that sequence. This works even for anterior intracranial extension. You can see that is resolved, and all that is left is at the superior orbital fissure, amenable to radiation. And of course, cosmesis is a bonus in these children. We don't have to do orbital excimeration anymore. So you can reduce this kind of a situation to a very nice cosmesis following multimodal treatment. With all this put together, the chance of life salvage in India is actually very high, up to 95 to 96%. And only about 1/3 of children still need primary enucleation. Earlier, it was about 75%. Chemo reduction works very well and has about 90% eye salvage. 95% of those who have eye salvage have some vision, and about 50% of them have very useful vision, more than 20/40. So in conclusion, I would say that retinoblastoma management has been standardized quite a bit in the last decade. It calls for individualized management based on the stage of the disease and the group of the disease. And of course, rest of it depends on the psychosocial situation and also where the parents are from, where the child is from, and what kind of travel they can put up. Mainly, it is cost-effective protocol-based management that is helping us save these lives. Thank you so much. Shall I go through the next one as well?
Yes, sir. Please, you can continue, sir. Thank you so much.
Sure. There are many intraocular tumors, not one. There are more than 50 intraocular tumors, but I will be able to concentrate only on the top 5: choroidal nevus uveal melanoma, uveal metastasis, choroidal hemangioma, and retinal hemangioblastoma. These are the top 5 intraocular tumors I thought would be useful for the postgraduates. Now, choroidal nevus is the most common benign intraocular tumor. Most common benign intraocular tumor is actually a ciliary body adenoma, but that is seen, that's a hidden tumor. So if somebody asks you what is the most common benign intraocular tumor, you can safely say it is choroidal nevus. Now, choroidal nevus appears as a pigmented lesion with a lot of secondary changes that are drusen and fibrous metaplasia on top of it, and there is no subretinal fluid. Generally, the size ranges from 3 to 5 millimeter in diameter and less than 2 millimeter in thickness. If something is thicker than 2 millimeter, you would suspect if it is really choroidal nevus that you're looking at. OCT actually helps us diagnose choroidal nevus in a suspicious situation. It's a placoid mass in the outer choroid, as you see here, compressing the choriocapillaries inward. These are the choriocapillaries, and you can see they're compressed in the area where the tumor is located without any subretinal fluid. That's how it looks on OCT. So if it's a choroidal nevus, you simply observe. As I said, choroidal nevus does not cause subretinal fluid or lipofuscin, which is an indicator of metabolism. So when there is thickness of more than 2 millimeter, when there is subretinal fluid, when the patient has symptoms of loss of vision or metamorphopsia, when there is orange pigment or lipofuscin, when the margin of the lesion is very close to the optic disc and fovea, it shows hollowing or on ultrasound, and there's a halo around it, and the drusen are absent. This is a mnemonic for diagnosing early melanoma, right? So TFSOM UHD to find small choroidal melanoma using helpful hints daily. This was by the Shields, but these are just these clinical checklists to help you differentiate a nevus from a melanoma. Now, this particular small tumor, which is hardly 3 millimeter in diameter, occurred in a physician, and he refused to believe the diagnosis. He waited for about 6 months. You can see that it has actually grown over a period of time. So what tipped us off about the diagnosis was not just the size, but the amount of lipofuscin pigment. So whenever you see lipofuscin pigment or orange pigment over a pigmented choroidal lesion and don't see nevus and see subretinal fluid, then it's a small melanoma that you're dealing with. Now, coming to choroidal melanoma, it is the most common primary malignant intraocular tumor. The most common malignant intraocular tumor, of course, is choroidal metastasis. Now, choroidal melanoma is one type of uveal melanoma, and uveal melanoma can occur in the iris, ciliary body, and choroid. These are examples of iris melanomas. Iris melanomas could be nodular, as you see here, but it always alters the iris architecture and causes neovascularization of the iris even in that sector. And this is the sectoral iris melanoma. You can see it is limited to one sector of the iris, and it could be diffuse involving the entire iris, as you see here with correctopia and ectopia nevae in NVI and high pressure. This is one example of a diffuse iris melanoma. This is called tapioca melanoma because of the nodular excrescences. And this is one more variant of diffuse melanoma. It is called the ring melanoma of the trabecular meshwork and the ciliary body. So it is like a ring all around the trabecular meshwork. Now, how do you treat iris melanoma? If it is sectoral like this, you can safely do a iridectomy and cure it. If it is extending to the periphery and to the anterior chamber angle, then you can do iridocyclectomy. Otherwise, the most popular treatment, most standard treatment is plaque brachytherapy. Of course, you can do enucleation for larger lesions like this. Now, ciliary body melanoma is generally not seen because it is hidden behind the iris, and the tip off, the earliest sign that you see of a ciliary body melanoma may be a vessel like this. This is called a sentinel vessel. A large dilated episcleral vessel, if you find in any patient, you should do a very careful fundus evaluation and indented evaluation. And if you still don't see anything, you should always do a UBM and confirm if there is any ciliary body tumor lying behind. Like this small ciliary body tumor can easily be missed even on a routine fundus evaluation, and you should give adequate weightage to a sentinel vessel. Now, ciliary body melanoma, if it's sectoral like this one, about 3 clock hours can be safely resected. It's called local resection, or you can do plaque brachytherapy. But of course, larger tumors need enucleation. Now, this is a very classic choroidal melanoma. Choroidal melanoma can have a collastoid appearance because of break in the Brooks membrane, and that is the anterior component of the lesion. That's the placoid base that this patient has. In cross section, it may look like this. This is the base in the choroid, and this is the break in the Brooks membrane, after which it becomes nodular. So it has this kind of a collastoid appearance. Otherwise, most of the choroidal melanomas look like this. They are nodular, more nodular, not having broken through the Brooks membrane, with subretinal fluid, as you see here, and little bit of orange pigment or lipofuscin, and no drusen at all. This is how choroidal melanoma looks like clinically. So indirect ophthalmoscopy still happens to be a very good tool in diagnosing choroidal melanoma. You can definitely take help from fluorescein angiography, ICG angiography, ultrasonography, OCT, OCTA, and even CT and MRI. But the most important tool would be an indirect ophthalmoscopy. What you see in OCT, unlike choroidal nevus, which compresses choriocapillaries, here you find subfoveal fluid in this particular patient, or wherever the tumor is, you find subretinal fluid with shaggy photoreceptors, altered photoreceptors, and a dome-shaped choroidal mass with overlying outer retinal thickening. This is what you find on OCT. Now, in autofluorescence, also you can see that the orange-colored lipofuscin pigment very beautifully shows up. And on fundus fluorescein angiography, you can find double circulation, and on ICG also has characteristic appearance for a choroidal melanoma. Now, in ICG angiography, even remotely, even if the lesion is located somewhere towards the periphery, you find a larger foveal avascular zone in the involved eye. Mild macular ischemia occurs in choroidal melanoma even before treatment. Now, how exactly do you treat choroidal melanoma? There are many considerations. One is, of course, the size of the tumor and what is the visual potential of the patient, what is the status of the opposite eye, age of the patient, and the general health of the patient. What guides us in treatment is the COM study. COM study was the first randomized study in oncology for that matter. It is called Collaborative Ocular Melanoma Study, where there were three things that were noted. One is pre-enucleation EBRT for large melanoma shows no advantage. So if you have a large tumor, you simply go ahead and enucleate. So enucleation is the standard of care for large tumors, which are about more than 8 millimeter in diameter or 10 millimeter in thickness and more than 16 millimeter in diameter. You simply go ahead and enucleate them. If it's a medium-sized tumor, then enucleation versus brachytherapy has no advantage as far as life salvage is concerned. So brachytherapy is the treatment of choice for medium-sized melanoma. For small melanomas, earlier COM studies had observation, but we don't observe them anymore, we treat them. So what is the treatment for small melanomas? It is transpupillary thermotherapy. Transpupillary thermotherapy works very well, but the scar that is produced is so significant that the patient often loses central vision if it is located in the macular area. Otherwise, medium-sized tumors are treated with plaque brachytherapy. Now, plaque brachytherapy can be done using either ruthenium or iodine. These are the two radioisotopes which are popular. Palladium can also be used, and you can treat up to 16 millimeter in diameter, 6 to 8 millimeter in thickness. And the dose that is delivered is very high, 10,000 centigrade to the tumor apex, but it has very gratifying cure rate of 90% tumor control. For tumors which are located around the optic disc, use a notch plaque. These are examples of plaque brachytherapy. Radiation retinopathy, of course, is a complication of plaque brachytherapy, but tumor regresses very beautifully, as you see here. Nice regression that you see here, and also a juxtapapillary tumor nicely regressed. Optic atrophy is a side effect in such situations. Of course, you can use other forms of radiation as well, and local resection of the tumor is also an alternative. You can see that this nodular tumor has been resected and the choroid is missing in that area, and retina has beautifully settled following local resection. Large tumors, of course, need to be enucleated. Now, what is new in choroidal melanoma is the genetic-based or classification of stratification of risk factors. So we have chromosome 3 loss, 8q gain, 1p loss, and 6q loss put together. This is called class 1 melanoma. This is associated with poor prognosis. And in such patients, you are justified in treating them with adjuvant therapy. Now, going on to choroidal hemangioma, it is the choroidal metastasis, which is the most common malignant intraocular tumor. Most common malignant intraocular tumor, because it is actually the most common. It is the secondary tumor. Most common primary malignant intraocular tumor is choroidal melanoma. Now, metastasis can be unilateral or bilateral. This is an example of a bilateral choroidal metastasis with multiple nodules, which are yellowish white. This is a large nodule here arising from a CA breast. This is also choroidal metastasis. You can see OCT picture here. The classic term that is used for choroidal metastasis on OCT is lumpy, bumpy tumor surface that you may want to remember. Choroidal hemangioma is an orange colored lesion which often occurs at the posterior pole, causing loss of vision, hyperopia, and metamorphopsia. The indications for treatment, of course, is the presence of subretinal fluid, hyperopia of more than 3 diopter, and metamorphopsia. It is the most common non-pigmented intraocular tumor. And in OCT, it shows smooth surface with expanded choroidal vascular spaces. You can see a very nice smooth surface of a choroidal lesion with expanded choroidal vascular spaces on OCT. And you also find subretinal fluid on OCT. That's one way of detecting very subtle subretinal fluid. Already mentioned what are the indications for treatment: increasing SRF with foveal threat, metamorphopsia, progressive tumor-induced hyperopia of more than 3 diopter, and secondary retinal changes. The standard of care for choroidal hemangioma earlier had been photodynamic therapy, but unfortunately PDT has gone away from the market, so we don't have the advantage of PDT anymore. So we have to resort to either transpupillary thermotherapy or plaque brachytherapy. Plaque brachytherapy gives nice results with choroidal hemangioma, whether it is diffuse or nodular. Now, the last tumor that I'm going to deal with is choroidal hemangioblastoma, earlier called retinal capillary hemangioma, which is the most common benign retinal tumor, not a choroidal tumor. And generally, you see these patients with posterior polar exudation, which is remote from the lesion, which finger-like projections of exudation towards the fovea should look in the opposite direction to find this retinal capillary hemangioblastoma. Once you cryo it and treat it, the tumor regresses, and so do the exudates, thus maximizing visual potential. These can also be treated with laser photocoagulation, transpupillary thermotherapy, photodynamic therapy, or plaque brachytherapy. But what is very important in patients with retinal capillary hemangioma or retinal hemangioblastoma is that they have systemic association. Systemic association in the form of VHL disease has to be investigated. These patients should be looked for with MRI brain for cerebellar hemangioblastoma, a high resolution CT scan of chest and abdomen for renal cell carcinoma and pheochromocytoma, and also pancreatic tumors. But retinal capillary hemangioblastomas are the first tumors that these patients develop. So ophthalmologist has a unique opportunity to see these tumors and investigate them for systemic manifestations. There are diagnostic criteria as well. This is the VHL screening criteria, which is age dependent. So every patient with retinal capillary hemangioblastoma has to undergo a genetic test first. And if VHL gene is positive, then you would investigate them systemically. Some patients may have an isolated retinal capillary hemangioblastoma without VHL disease, and the family also has to be investigated similarly. So that's a very short summary of intraocular tumors. Thank you so much.
Thank you so much, sir. As always, it was very engrossing and aided by lovely pictures for them to see so they could understand better.
Thank you.
I now invite Dr. Virendra Sachdeva. He is a consultant in pediatric ophthalmology, strabismus and neuro-ophthalmology in Nimegada Prasad Children's Eye Care Center. He is actively involved in teaching and in his research work, which has been presented at various national and international forums. Welcome, sir. We're very happy to have you with us.
Am I audible?
You're audible, sir, but the volume is a little low.
Is it better now?
It's better now, sir. Thank you.
Okay. Good evening, everyone, and thank you very much for the kind invitation. It was a wonderful talk listening to Dr. Santosh and all the previous speakers. Thank you for the invitation, and I'll be talking to you all on a very important topic, which is like how to approach a patient with disc edema. I think this is something which is very common that we see in various general ophthalmology as well as neuro-ophthalmology clinics, and I would try to cover it in a systematic manner, trying to highlight some of the important key points. So when we see a patient with disc edema, we are concerned whether there's a papilledema or it's just a disc edema. We'll understand differences between them. How to approach a patient with papilledema will be dealt with as a distinguishing between a true papilledema versus pseudopapilledema, distinguishing between disc edema versus an optic neuropathy. Then I will highlight some common etiologies with the help of examples and provide the approach to dealing with them, and suggest algorithm for the workup of a given patient with disc edema. So let's begin with a case. This is a 38-year-old housewife who presented to us with complaints of blurring of vision and double vision for distance and near since 15 days. She was diagnosed as having bilateral disc edema and was referred to us for further evaluation and management. When we retook the history, she accepted a history of having headaches for last 2 weeks, transient visual obscuration in both eyes, and there was no associated nausea, vomiting. Her systemic history was significant for past history of asthma for last 20 years, and she had been on oral steroids in low doses for control of asthma. She was recently put on a new Ayurvedic medicine for her control of asthma, and there was also history of weight gain. So we have a patient who comes to us with blurring of vision, diagnosed as disc edema, the history of headaches, transient visual obscurations, history of using oral steroids, and weight gain following a new medicine. The ocular examination was showing a good visual function. Their visual acuity was 20/25, 20/30 in right eye and left eye. Color vision was normal. West anterior segment was normal, and pupils were round, regular, and reacting to the light and accommodation. Coming to the ocular motility of the patient, we can see that there is a small esotropia in the primary case, and there is a epiduction limitation in both eyes, right eye more than left eye. Fundus examination showed presence of a marked disc swelling with presence of associated hemorrhages, some peripapillary lines like the Patton's lines, presence of hard exudates which were radiating to the macula, and very few soft exudates. So this was the patient who was classically having disc edema in both eyes. Now, what should be our approach in dealing with these patients? First, let's see what is difference between disc edema and papilledema. Papilledema is presence of an optic nerve head swelling which occurs secondary to a raised intracranial pressure. So you can say it only when the diagnosis has been proven with presence of a neuroimaging or documented elevated opening pressure. So the common etiologies are like cerebral sinus venous thrombosis, idiopathic intracranial hypertension, and intracranial neoplasms, either of the posterior fossa or large enough to cause a midline shift. Optic disc edema, in contrast, is a swelling of the optic disc with or without an increase in the intracranial pressure. So this could be occurring from the intraocular or the optic nerve pathologies as well. For example, VKH syndrome, central retinal vein occlusion, and certain other common optic nerve pathologies like optic neuritis and non-arthritic anterior ischemic optic neuropathy, which can cause a disc swelling, but there will not be elevated intracranial pressure. So, point to remember here, or the first point that we should remember, is that optic disc edema is a broader term that we can use to describe a patient with optic disc swelling, irrespective of elevated or normal intracranial pressure. It does cover many pathologies, which can be in the eye itself, whereas papilledema is the term that you should use only when there is an elevated intracranial pressure. As postgraduates, you might be asked to specify the difference between the two. Now, the next question that comes to us is that how to differentiate between true disc edema versus a pseudo disc edema. So we see here two pictures, one to your right side of screen and on the left side of the screen. Both are showing presence of optic disc swelling. You can see that optic disc is elevated in both eyes, and there is blurring of the disc margin. So if we look at only the mechanical signs over there, we can definitely see that there is presence of the optic disc swelling in both eyes, and it could be a presence of a optic disc edema. However, if you see the picture on the left side, you can also see there are vascular signs like there is presence of hemorrhages, soft exudates, and there is blurring of the disc margin. You can even see that there is presence of the few telangiectatic blood vessels on the surface of the optic disc, like you can see here. So given this presence of vascular signs are the things which are occurring secondary to the dilatation of blood vessels, and this is characteristically seen in true disc edema. Whereas presence of only mechanical signs like disc elevation, blood margins are signs that could be seen even in a pseudo disc edema. It is easy to distinguish in this case. However, if I will just first try to describe again what are the true signs or the vascular signs that you would be using to distinguish between true disc edema versus pseudo disc edema. So blurring of the or obscuration of the peripapillary RNF layer, presence of peripapillary flame-shaped hemorrhages, Patton's lines, hard exudates, cotton wool spots. These are the vascular signs. When this is the picture, it is very easy to distinguish between a true disc edema versus a pseudo disc edema. However, in case you are seeing a very mild disc swelling, it might be difficult to distinguish. Like in this picture, we saw the central picture previously also. It's a patient with a pseudo disc edema, and there is a lumpy bumpy appearance over there. This is possibly a patient with a optic disc drusen. On the right side of your screen is another small looking disc with mild hyperemia of the disc over here, and this is actually a patient with a small disc which is mimicking like a disc edema. But if you see carefully, the blood vessels over the surface of the disc are going smoothly and there is no blurring of the disc margins. In contrast, the picture to the left side of the screen is showing another patient where there is actually presence of cup but very mild disc elevation. If you see more carefully this picture, you can see that there is obscuration of the peripapillary RNFL, as can be seen especially on the nasal side, and there is obscuration of the blood vessels, especially the smaller blood vessels, as they are crossing the optic disc. So in a patient with true disc edema, even if it is mild, go back, use magnification, use your slit lamp biomicroscopy and use 90D lens or 78D lens to look at the disc carefully. You will be able to pick up the blurring of the disc margins, obscuration of periperipheral RNFL, as well as the obscuration of the blood vessels as they are crossing the surface of the disc. So this is how you will distinguish a patient with mild papilledema versus a pseudodisc edema. Coming to the fourth important issue in dealing with these patients is, when you are seeing a patient with disc edema, are you dealing with a papilledema or an acute optic neuropathy? We did see some differences between pseudodisc edema and papilledema as well. So how do you distinguish between three important conditions that come to you in the clinic? So look for the associated visual symptoms in these patients. In a patient with acute optic neuropathy, there is usually an acute vision change and the color vision is abnormal. If you do the visual fields, there is usually a dense scotoma. So the patient will come to you with a vision change. You will see abnormality of color vision, and the field defect will be like a central scotoma or a large central scotoma or a diffuse field defect. There could also be altitudinal field defect if it's an anterior ischemic optic neuropathy. Whereas in a patient with papilledema, there is a gradual blurring of vision. Patients might complain of transient visual obscurations. There is usually normal color vision, and there is an enlargement of the blind spot. In contrast, patients with pseudodisc edema are often asymptomatic. They will have good vision and color vision, whereas the visual field in these patients tend to be normal or might show only a nasal depression. So given this change in the vision and the associated visual symptoms, color vision, and the visual field changes, you can distinguish between all of these. Now, fifth thing that we would like to see in a patient with papilledema is like how to distinguish whether the disc edema is occurring secondary to a retinal pathology or a systemic pathology that could be causing. This is important because this could avoid us from doing an unnecessary neuroimaging in a given patient. So let's see. If we look at these two pictures, see the picture on the right side of your screen, you can see a patient with the disc edema and hyperemia, but you can also see presence of associated subretinal whitish lesions. There is actually a sensory elevation of the optic of the retina. There is a presence of fluid below it, and there is a neurosensory detachment. This is a patient actually with a VKH, which is actually causing the secondary optic disc edema. Let's see the picture on the left side of the screen. You can see a patient with a hyperemic disc. You can see disc margins are blurred, but see again, there is presence of splinter hemorrhages, there is cotton wool spots and hard exudates. What is characteristic in this patient is that there is presence of marked attenuation of arterioles. They are very much narrow. This is a patient who had an accelerated hypertension, and that was the cause of the disc edema. So it's a malignant hypertension in this patient. So it is important to look at the associated retinal signs and take a detailed look at the neighbor of the optic disc, that is the adjoining retina, that will be able to tell you what is the likely cause in these patients. Let's quickly take a few examples. So this is the first patient that we were discussing, young woman, history of steroid intake, weight gain, blurring of vision, diplopia, TVOs, extraocular motility limitation, and bilateral disc edema. So this patient doesn't fit into the previous retinal signs. This is a true disc edema. We will definitely need a neuroimaging, and neuroimaging showed presence of empty sella, presence of flattening of the sclera, elevated optic nerves, and there is enlarged perioptic nerve sheath. These are the signs of raised intracranial pressure, but there is no other brain pathology. So this is a characteristically a patient that fits more like a patient with a idiopathic intracranial hypertension. But before you do that, you should ensure that MRV brain is also normal. So the MRV brain does show presence of narrowing of the transverse sinuses at the junction of transverse and sigmoid sinus, but rest of the venogram is normal. There is no CSVT. The CSF opening pressure was 32 centimeter of water, while rest of the CSF was normal. So this is a patient with idiopathic intracranial hypertension. These are the current diagnostic criteria, which basically tell that there is papilledema, normal neurological examination except for cranial nerve abnormalities, especially bilateral sixth nerve palsy. Neuroimaging should be normal except for signs of raised ICP, normal CSF composition, and elevated CSF opening pressure according to the age. And it should be done in the proper manner in the left lateral decubitus position. You could also have IIH without papilledema, which is uncommon, but it should be matched when there is at least presence of the three of the following neuroimaging criteria, like empty-cella, flattening of posterior aspect of globe, distension of perioptic subarachnoid space, and transverse venous sinus stenosis. Let's move to the another case. This is a 32-year-old woman who presented to us with poor vision in both eyes for 2 months, headaches for 2 months, and now started to have double vision in either gaze. Her visual acuity was markedly diminished. Anterior segment examination showed pupils were ill-sustained reaction. So there is bilateral abduction limitation again in this patient, this time left eye more than the right eye. Okay, you can see in the picture. And there is presence of disc edema with presence of pallor setting in. So it's possibly going into optic atrophy. We obtained neuroimaging again in the patient, and you can see that patchy hyperintense lesions which are present along the meninges. So this is a patient with suspected meningitis, and the CSF analysis showed positivity for AFP, and patient was diagnosed and treated as tubercular meningitis. This patient had papilledema and bilateral six-nerve palsy secondary to tubercular meningitis. What do you learn from this case? It's the last two cases. When there is papilledema along with cranial nerve dysfunction and presence of headache, TVOs, it suggests integral pathology. Neuroimaging will be mandatory. It should be MRI brain and orbits with contrast, and MRV should be obtained to rule out a CSVT also. Many a times CSF analysis will also be necessary in these patients if you don't find a structural lesion. Moving to the next case, it's a 40-year-old male who presented to us with blurring of vision for 7 days. No other significant history, not diabetic, not hypertensive, but was referred to as a case of papilledema. BCVA was reduced, and this is the picture showing typical features of a malignant hypertension with disc edema, splinter hemorrhages, soft exudates, radiating all over. This was easy to pick up, and we selected the patient to simple BP checkup, and the diagnosis was easy to establish. And the patient further on the workup was found to have a life-threatening disease, bilateral renal artery stenosis. In a very early case, you may not have all the signs, but look for the attenuation of arterioles. That could be the first clue for diagnosis of malignant hypertension. Another patient who was a middle-aged man referred to us for sudden onset diminution of vision in both eyes for 1 month, and the patient was non-diabetic. Patient was diagnosed to have hypertension after this episode of vision loss, and the patient visual acuity was good in the right eye, but left eye was markedly diminished. There was relative afferent pupillary defect in the left eye, and the fundus picture showed presence of bilateral disc swelling. You can see in the left eye there is presence of multiple hemorrhages, there is presence of edema and hard exudates which are radiating to the macula like a neuroretinitis like picture. But in the right eye, you have some more clue. There is a segmental edema of the inferior portion while superior segment is becoming pale. That made us subject think that this could be NION. We did obtain visual fields in this patient, and it showed a presence of an inferior alternate field defect in the right eye is on the gray scale, but on the total division plot, there was again advanced field effect from the pallor and the edema in the superior inferior segments. Left eye, very advanced field loss. So this was a patient with bilateral NION, which is rare in a patient to occur simultaneously, but can be possible. So this is again a possibility that you should keep in mind, especially unilateral patients or a patient with pseudofoster Kennedy-like syndrome. This is another example of a patient who presented to us with, who was a 24-year-old woman, presented to us with sudden onset diminution of vision that progressed over 2 days to complete loss of vision. There was no other neurological problems, but the patient had pain on eye movements. This is an important history in a young woman presenting to us with complete loss of vision, and there was no other systemic risk factors. Visual acuity was only light perception. So you see a patient here with acute vision change and bilateral disc swelling as seen in the fundus photographs. This was a patient with bilateral papillitis. Another patient whose fundus photograph showed unilateral optic neuritis with unilateral disc edema. The MRI is very much needed, especially MRI of orbits, which shows presence of the thickening of the optic nerve and swelling, and presence of the contrast enhancement that is characteristic in these patients. So these patients again will require a neuroimaging. Coming to another scenario, this is a 32-year-old female who presented to us with sudden onset loss of vision in right eye for 1 day. There was no history of pain, photophobia, trauma. Visual acuity was markedly reduced in the right eye. left eye was normal and there was grade 1 RAPD in the right eye. But there is no other relevant history that is coming up. Look at the picture. This is similar to the picture I showed you before. Look at the neighbor. The disc is swollen, but there is presence of multiple outer retinal lesions. There is presence of neurosensory detachment. This is a patient with a possible VKH, and you need only a FFA to confirm the diagnosis. You can see that there is presence of the hypofluorescence in the early phases with a late leakage that is characteristic in these patients, and diagnosis can be established clinically. The choroidal, the B scan also helps in making the diagnosis by picking up choroidal thickening. Okay. LH1 should be considered in young and adolescent males with bilateral sequential loss of vision. Presentation could be similar to optic neuritis, but vision loss could be marked and it can be progressive, it may not improve. Usually at presentation, there is marked hyperemia of the disc and there could be some telangiectasias on the surface of the disc. So if you look at carefully the patterns, the unilateral disc edema is usually secondary to an optic nerve pathology or intraocular pathology, whereas bilateral disc edema is just a systemic disease like hypertension, could be a diffuse CNS process like meningitis, IH, or cerebral sinus venous thrombosis. So you should be carefully distinguishing between the two. If you look at the causes of unilateral disc edema, you can keep this approach. Rule out pseudodisc edema. If it is not a pseudodisc edema, look for the optic nerve pathologies, optic neuritis, NAION, optic nerve tumors, and your retinitis should be considered. Do rule out the retinal pathologies like there is intraocular inflammation, sarcoidosis, serpiginous choroiditis, VKH, and very, very rarely when nothing is found, then it could be secondary to a diffuse process affecting one eye asymmetrically. Bilateral disc edema, we discussed malignant hypertension is something that you would like to rule out always. Rule out raised ICP, which could be primary, secondary. Look at vision loss, that could be clue that it could be optic neuritis. There could be other multiple causes that we need to keep in mind, but it would require multiple neuroimaging, blood investigations that would be needed in these patients. We discussed that there could be multiple causes of disc edema. So how do you distinguish papilledema versus disc edema with normal ICP? Is the looking at the symptoms. Transient obscuration of visions are common with papilledema. Symptoms are usually insidious. Usually they have neurological deficits, ocular motility problems could be there. But rest of the eye examination is normal in the anterior segment, vitreous is normal, and usually field show enlarged blind spot. Whereas in patients with disc edema, due to optic nerve problems, retinal problems, there could be vision loss, which could be transient or showing transient obscurations, or more importantly, or more likely, it will be usually an acute vision loss. Onset is usually sudden. There are things that can be there like hypertension, diabetes, dyslipidemia. There could be anterior chamber cells, posterior vitreous cells, which suggest it's a retinal or intraocular pathology in these patients. And disc elevation is usually mild to moderate as compared to raised ICP, where it is usually more marked. Keep these things in your mind when you are dealing with a patient. It's important things in history you would like to elicit are presence of history of hypertension, diabetes, CAD, which could suggest an ischemic disease, history of infectious disease like tuberculosis that could suggest a CNS involvement. History of HIV is important because HIV can cause optic neuropathy as well as meningitis. There could be history of recent exposure, travel, playing with the pets, recent change in climate, which is observed in patients with neuroretinitis. You want to obtain a blood workup for ruling out these important risk factors in a patient with suspected NAION. Visual fields help when you are suspecting the patients to have intraocular pathology, like there could be optic neuritis, toxic optic neuropathy, or LHON, which can have a central or a centrocecal scotoma. Altitudinal field loss could be observed in patients with NAION, and there could be enlargement of blind spot that could be seen in patients with raised ICP. Neuroimaging is often needed, as I stressed before. The algorithm that you could follow in a patient with papilledema, or say more important, say with a patient with disc edema, would be that you look carefully, always check the BP, take ocular and systemic history, try to rule out a pseudo disc edema. If it is likely to be true disc edema, distinguish between papilledema and optic neuropathy. If there is an optic neuropathy, do a suitable workup. if it's not an optic neuropathy, we are dealing with a patient with possible intracranial pathology. So you need an acute neuroimaging, which has to be MRI brain with contrast with MRV brain. You want to rule out intracranial mass or hydrocephalus. If it is not there, look at the cerebral venous sinuses. There should not be CSVT. Look at the meningeal enhancement. It could be meningitis. If any of this is found, CSF culture will be needed. If meningeal signs are there, CSF culture will be needed. If these are normal, then you suspect IH. You need a CSF analysis and a CSF opening pressure that could give clues to the final diagnosis. So this is a simple approach that you can follow, and it is given very well with the various examples in the text need of thermal illustrated. You could follow from there. Thank you very much for the opportunity and the patient hearing.
Thank you so much, sir. I mean, the finding of disc edema itself makes most of us nervous. You broke it down and explained it really well. We're very happy to have you. Thank you for your time.
Thank you. Thank you so much.
Next, we have Dr. Soundari, who needs no introduction really. She is the Regional Head of Clinical Services with over 20 years of experience. So as we all know, she's keenly involved in teaching all of us, all postgraduate students. She has a wealth of knowledge and a special interest in neuro-ophthalmology. Thank you, ma'am.
Thank you, Vaishnavi. Today we are going to talk about pupil. So this is a very important and interesting topic for postgraduates. So normally pupil, if you look at the size of the pupil, it is between 2 to 4 millimeters. It has sphincter pupillae, which allows the pupillary constriction, and radially arranged dilator pupillae, which allows the pupillary dilatation. The pupillary constriction is by the sympathetic, constriction is by the parasympathetic, and dilation is by the sympathetic. So when you do a light reflex, what are the prerequisites? The room light should be dim, and you should not be standing in front of the patient so that you don't induce an accommodation, and you show a bright light of torchlight from the side to look at the pupillary reflex. So what is the pupillary pathway? So when the light is shown onto the eye, the light falls on the retina, stimulates the retina, and it passes through the optic nerve, chiasma, and through the optic tract. Before it enters the LGB, it branches out through the superior brachium to enter into the pretectal nucleus. In the pretectal nucleus, there is crossing of the fibers, and it crosses and passes along the same side also to the Edinger-Westphal nucleus. From the Edinger-Westphal nucleus, it passes through the third nerve and synapses in the ciliary ganglion, and through the short ciliary nerves, through the nerve to the inferior oblique, it supplies the sphincter pupillae. Since there is crossing of the fibers at the optic chiasma as well as at the pretectal nucleus level, so you have the pupil of the same size in both the eyes, whatever be the lighting conditions. So what is anisocoria? When there is a difference in the pupil size between the right and the left eye, you call it as an anisocoria. It could be a physiological anisocoria or a pathological anisocoria. So physiological anisocoria, when do you call it? When the size of the pupil, the difference between the size of the pupil between the right and the left eye remains the same in the bright light as well as in the dim light. Then it is the same, it is a physiological anisocoria. Pathological anisocoria, how will you find out whether the dilated pupil is the abnormal pupil or the constricted pupil is the abnormal pupil? So what happens in the dilated? So when you put on a bright light, the pupil should constrict. If the pupil is not constricting, then the dilated pupil is the abnormal pupil. So hence the dilated abnormal pupil is well appreciated in bright light. Causes of dilated pupil being amerotic pupil, ADs, traumatic, third nerve palsy, and pharmacological dilatation. And in case of constricted pupil, so this can be well appreciated in dim light. So in dim light, the pupil has to dilate. If the pupil doesn't dilate, then the constricted pupil is the abnormal pupil. So the causes are Horner's, Archer-Robertson pupil, and pharmacological constriction. So what is an amerotic pupil? Amerotic pupil is when the complete nerve damage is there, the pupil is dilated and fixed, you call it as an amerotic pupil. So if the nerve damage is partial, then you call it as a relative afferent pupillary defect or a Marcus gun phenomena. So if you look at the Marcus gun, you do a swinging flashlight test. So you swing the light from one eye to the other and quickly look at the pupillary reaction. In this case, if you look at the right eye pupil and the left eye pupil, keep swinging the flashlight from right to left. You can see that there is a pupillary escape on the left side, stating that there is an RAPD on the left side. So in this patient, if you look at it, the swinging flashlight test is being performed, and you can see that there is a right RAPD. When the light is shown onto the right side, the pupillary dilatation happens instead of the constriction. So this is a right RAPD. So do you have a terminology called as a bilateral RAPD? No, it is a relative afferent pupillary defect. So if there is a bilateral optic nerve pathology, then how can you find out? What you can do is a pupil cycle time. So pupil cycle time is one thing in which you make a very thin slit of light, either vertically or horizontally at the edge of the pupil. As the light enters the pupil constricts and the light is cut off. And then again, the pupil dilates. This kind of a pupillary constriction and dilatation is considered. And that's how you get the pupil cycle time. Hundreds of cycles are being taken into consideration. The time taken is multiplied by 10, which gives you the pupil cycle time. This is in cases of bilateral optic nerve pathology, as in case of a thyroid eye disease. The normal is around 840 milliseconds. The abnormal is the difference between the two people if it is more than 70 milliseconds, or if one eye has got more than 954 milliseconds. What is an Aries pupil? Aries pupil is a large unilaterally dilated pupil, absent or poor light response, near slow tonic contraction occurs. Why does the tonic contraction occurs? It's basically because of the nerve supply being in the ratio of 30:1 to ciliary body to the sphincter pupillae. So hence there is a slow tonic contraction while there is an absent or poor light response. And when do you call it as a Holmes-Addy syndrome? Is when there is an absence of deep tendon reflexes. And if an Aries pupil is present in less than 1 year of age, you should think of familial dysautonomia. So this is a patient who presented to us with a complaints of defective vision for reading, and he has got a minimal glare. So when you look at it, you look that the pupil is dilated. The left eye pupil is definitely dilated. You can see, and when the light is shown, there's not going to be much of a reaction to this pupil. So there is a very slight constriction, which is not very brisk. So this is the same patient. We are putting him on the slit lamp and we are examining him. So you put on the light and you can look for pupillary constriction. So the pupillary constriction doesn't happen. You can see the loss of sphincter over here, over here. So usually you have a vermiform contraction. So the vermiform contraction can be very well appreciated. Look at the 6 o'clock position. You can see a nice vermiform contraction because the sphincters are there here, while there is a loss of sphincter over here. Yeah, you can see the nice vermiform contraction, which is very classic of Aries pupil. So how do you confirm Aries pupil? By using a 0.125% pilocarpine, which is 1/1/8 of a pilocarpine, 1% pilocarpine. So when you put this 0.125% pilocarpine, what happens is there is a pupillary constriction of Aries pupil. Why does this happen? Because of the denervation supersensitivity. Does it happen in every patient of Aries? No, not immediately after the Aries is diagnosed. Usually it takes some weeks for the pupillaries, for the denervation supersensitivity to settle and the pupillary constriction to happen. And 0.125% pilocarpine can be given as a treatment for Aries pupil also. If you look at it, look at the pupillary dilatation before 0.125% pilocarpine, and this is after the same eye. You can see the pupillary constriction being very good. So the other condition in which the pupillary involvement is there is going to be a third nerve palsy. But this is a very easy condition because there will be a complete ptosis, the extraocular movements are affected. So whether the pupil involvement is there or not there is what you need to look at. to know whether the pupil involvement is there means it's a surgical third nerve, and if the pupillary sparing is there, then it's a medical third nerve. So you can see a patient of a third nerve. You can see a complete ptosis on the right side. On lifting up the lid, you can see that the eyeball is down and out. On checking up the extraocular movements, the adduction is limited. The elevation is limited. And the depression is also limited. And the pupil was dilated. So this was a case of a surgical third nerve. So what is a third nerve misdirection? So third nerve misdirection happens in surgical causes or compressive neuropathy, not in ischemic third nerve palsy. So what is the third nerve misdirection? When the nerve regenerates, this nerve fibers gets redistributed and resulting in pupil gaze dyskinesis. What is a pupil gaze dyskinesis? There is a pseudo-Orgel-Robertson pupil. When the patient tries to adduct, the pupil constricts, which is called as a pseudo-Orgel-Robertson pupil. And pupillary constriction on looking down. So this is a patient of a pseudo-Orgel-Robertson pupil. You can see, look at the pupil. When we ask the patient to try to adduct, you keep looking at the pupil will constrict. And he moves out, the pupil dilates. So this is a very classic case of a pseudo-Orgel-Robertson pupil. This is a case of a third nerve misdirection. You can see the pupillary constriction. When the patient tries to look straight, yes, the pupil
We're not
is
able to
dilation.
see the video, ma'am.
Huh?
Video is not playing.
Oh, it's playing for me, is it?
Yeah, it's not playing here.
Okay. Leave it. Then no, it's there in the folder only. That's okay. Can you go to the I will see if I can present it separately. It's a very nice video. So it classically shows pupil gaze dyskinesis, and there is a lid gaze dyskinesis in which there is an inverse Jouans when there is a lid retraction on attempted adduction and pseudo-von lid lag on down gaze. I have a video for this also. I'll try to play it at the end. So pharmacologically dilated pupil, they usually do not respond to 2% pilocarpine as the receptors are blocked. Example being pharmacological agents being atropine, homatropine, and cyclopentolate. So anisocoria in a dilated pupil, how do you differentiate pharmacologically? Use a 0.125% pilocarpine. If the pupil constricts because of the denervation supersensitivity, it's a postganglionic lesion, which is called as an Aries syndrome. And if the pupil do not constrict with 2.125% pilocarpine, use a 2% pilocarpine. On using a 2% pilocarpine, if the pupil constricts, it's an anatomical lesion like a third nerve palsy. If the pupil do not constrict, the dilatation was due to atropine because it blocks the receptors. And in cases of traumatic mydriasis, you can see other signs of trauma like osseous ring, and you can see the sphincter tears, and sometimes vitreous hemorrhage and all that can be made out, and traumatic cataract can be there. So these are some of the causes for a dilated pupil. And Wernicke's hemianopic pupil, it's very, very difficult to elicit the Wernicke's hemianopic pupil because in cases of optic tract lesions, you can have one half of the pupil reacting to light and the other half not reacting to light, which is very, very difficult because you have to make a very thin slit beam of light to show that. So coming to the sympathetic pathway. So the sympathetic pathway, actually, it starts from the from the hypothalamus. The first order neuron starts and ends at the ciliospinal center of Budge. From the ciliospinal center of Budge, the second order neuron starts and passes through the inferior cervical and middle cervical ganglion, but does not relay in these two and relays in the superior cervical ganglion. After getting relayed in the superior cervical ganglion, the third order neuron starts and passes through the common carotid, and the pseudomotor fibers exit through the external carotid, while the remaining fibers pass through the internal carotid artery plexus and passes through the nasociliary nerve, and it passes through the ciliary ganglion but does not relay in the ciliary ganglion, and through the long ciliary nerves supplies the dilator pupillae. So what could be the lesions? So in cases of central horners, when we call it as a central horners, when there isn't the problem is in the first order neurons, as in case of a cerebrovascular accidents, tumors, and all that. In cases of second order neurons, it is called as a preganglionic honors, usually associated with the thyroid problems or with the lung cancers. It can be affected. And the third order neurons is postganglionic. It can be associated with the internal carotid artery aneurysm and dissections, and all that can lead on to a Horner syndrome. So any Horner's is actually is very, very important to diagnose and identify the condition why the patient has got a Horner's. So the Horner's people, basically you have a meiosis, partial ptosis because the Muller's muscles are not functioning effectively, and inverse ptosis because the lower limb retractors are not functioning effectively. Because of the partial ptosis and the inverse ptosis, you have an apparent enophthalmos. There is no true enophthalmos, there is an apparent enophthalmos. And anhidrosis, when the external carotid plexus which are passing through, that carries the pseudomotor fibers, and if they're not functioning, you have an anhidrosis and loss of ciliospinal reflex. So these are the symptoms in Horner's. You can see this video in which you can see there is a partial ptosis on the right side, and on examination you can see that the pupil is myotic. So this patient was a case of a Horner's syndrome in the right side. So in congenital Horner's, there are certain differentiating features, which is a heterochromia iridis. The sympathetic stimulation is important for the pigmentation, for the melanin pigments, and basically, so in congenital Horner's, you have a light colored iris and low IOP. And in an adult, if suddenly the patient is developing a Horner's, they tend to have the reading closer because of the increased accommodation. So how do you differentiate a Horner's from the normal pupil? So cocaine test. So cocaine test is what we normally do to differentiate a Horner's from a normal pupil. The normal pupil will dilate while the Horner pupil does not dilate. The mechanism is it prevents the reuptake of norepinephrine. So, and then to differentiate the preganglionic from the postganglionic, you use a 1% hydroxyamphetamine test. But the only thing is, because both are working at the receptor level, so the cocaine and the hydroxyamphetamine should not be done within 24 hours. So you should give a gap of at least 24 hours before you go in for the 1% hydroxyamphetamine test. In this, the preganglionic dilates while the postganglionic doesn't, because the preganglionic, why? Because of the release of the norepinephrine from the receptors. In postganglionic, basically it's because of the denervation supersensitivity. It responds to 1 in 1000 adrenaline test. So what is a light-near dissociation? So when does a light-near dissociation happen? It happens in Archer-Robertson pupil, which is most commonly associated with syphilis and other conditions. Aries pupil, we have already discussed. It can happen in diabetes, alcoholism, and Perinaut syndrome. So to sum up, what are all the pupillary abnormalities if you need to look at? So if the complete optic nerve is damaged, you call it as an amaurotic pupil. And only a partial optic nerve damage, you call it as a Marcus-Gunn pupil. And when the optic tract is involved, you call it as a Wernicke's pupil. And when the pretectal fibers, internuchal fibers are involved, you call it as an Archer-Robertson pupil. And when the third nerve is involved, you have a pseudo-Archer-Robertson pupil. And when the ciliary body is involved, or post ganglionic fibers from the ciliary body, when it is getting involved, you call it as an Aries pupil. Apart from that, other conditions which can have pupillary abnormalities could be a trauma causing an eccentric pupil, or iatrogenic, or could be an eye syndrome where there can be a polychoria and pseudo-chorectopia. Thank you so much for patient listening, and wish you all a very happy Diwali.
Thank you very, very much, ma'am. You made a very scary topic quite interesting. Thank you so much. Our next speaker is Dr. Preeta. Ma'am is a senior consultant in our hospital. She is the chair of the education community of our clinical board, and an anterior segment surgeon with a special interest in neuro-ophthalmology. Teaching has always been her passion right from her student days. Welcome, ma'am.
Hello. Am I audible? Is my screen visible?
We can hear you, ma'am.
Yeah. Is my screen seen?
Yes.
It is seen.
Yeah. Hi, my name is Dr. Preeta. I'm working in Dr. Agarwal's Eye Hospital. First, I would like to thank the Kalpavriksha team for having me here and giving me the topic that I'm actually really interested in. I really love neuro-ophthalmology because my teachers have kind of taught me neuro-ophthalmology like mathematics. So there is nothing to mug up. you can just work out what the patient has. So when the patient comes into the clinic, it will be like a puzzle for us. But as we start going step by step, we'll be able to work out what is exactly happening with the patient. So it's basically you have to just unravel the problem, and the answer will be there right in front of your eyes. So cranial nerve palsies, it's a huge topic, which is actually very difficult to shorten within 15 minutes, but I'll just try to make it as concise as possible, just talking only about the most important points. So initially, when a patient walks in and you're thinking that it is a cranial nerve palsy, he comes in with diplopia. So what you start looking at is, when the patient walks in, his head posture, even his gait, because we are going to do a neurological examination as well. A facial asymmetry, we should look for proptosis, ptosis. Then we should start doing the ocular motility, look for lag of thalamus. Then vision, color vision, visual fields, which are basically functions of the optic nerve, and look for convergence, corneal sensation, pupil, diplopia charting, Hess charting, facial sensation, fundus, and also systemic examination, basically sensory motor system and cerebellar tests. Investigations, since most of these cranial nerve palsies happen because of microvascular diseases, you should look out for blood sugar, HbA1c, BP, ESR, CRP to rule out any inflammatory problems. Hess charting is important not for diagnosis, but basically for the prognosis of the patient, and imaging as and when required. We'll discuss each cranial nerve in detail. Management first is treat the cause. Wait for the cranial nerve to get better, because sometimes it just gets better slowly. Treat the patient with glasses with prisms or fog glasses and taping of one eye, botulinum toxin injection, and appropriate surgery. So first we'll come to the oculomotor nerve. This is the third cranial nerve, which supplies most of the extraocular muscles. The nucleus is basically in the midbrain at the level of the superior colliculus. Why this is important is, basically the superior rectus muscle is supplied by the contralateral cranial nerve nucleus, and the LPS is supplied by the common central caudal nucleus. And this nerve has the parasympathetic supply from the Edinger-Westphal nucleus, like what was discussed in the previous topic. It divides into superior and inferior division, supplying the superior rectus and LPS by the superior division and the rest of the muscles by the inferior division. What causes oculomotor nerve palsy? So most common causes are vascular disorders like diabetes, hypertension, posterior communicating artery aneurysm. As you can see in this picture here, the optic chiasma, the oculomotor nerve, it's all very close to the posterior communicating artery, and any aneurysm can cause a problem in the oculomotor nerve. Trauma can also be a reason, tumor, inflammations, infections, demyelinating diseases, cavernous sinus thrombosis, carotico-cavernous fistula, ophthalmoplegic migraine, and congenital reasons. It can be an isolated third nerve palsy, or it can be part of multiple third nerve palsy. It can be a divisional third nerve where the superior or the inferior division is affected, depending on the location of the lesion. It can be a total third nerve where the pupil is also involved, or a partial one where the pupil is paired. Can be a complete nerve palsy where all the muscles are affected equally. Incomplete where the affectation of the muscle is not similar. Can be an evolving third nerve. This is most important because sometimes we think it's a vascular third nerve palsy when the pupil is spared, but the patient may have an evolving third nerve palsy and pupil may start getting involved slowly. So in these kind of patients, you should start telling the patient to look out for problems, pupillary dilatation, so they can have problems with near vision. We should ask them to check for anisocoria in the mirror also. Whereas it's a bit difficult in Indian eyes because of the dark color, but we can, if the patient is well educated, we can just advise them to check for the pupillary size. That means it's a surgical third nerve palsy involving the pupil also. It can be a palsy or a paresis. And aberrant regeneration of the third nerve, which is more common in post-traumatic and compressive lesion. This was discussed in the last talk. So again, this is a video which shows the eye, complete ptosis, eye being depressed and abducted because of the overaction of the lateral rectus muscle. As you can see, the movement is restricted in all directions. Abduction is maintained, and the rest of the muscles are all affected. Intorsion has not been checked in this video. There are a few indications for imaging. pupil involving third nerve cranial nerve palsy is needs imaging. When it is associated with other neurological signs and symptoms, again we have to do imaging. Part of multiple cranial nerve palsies, or divisional cranial nerve palsy, evolving cranial nerve palsy, which again becomes a surgical cranial nerve palsy, third cranial nerve palsy, or with aberrant regeneration without history of trauma, imaging is very, very important. One of the emergencies in ophthalmology is having a PCA aneurysm. Patient will present with a severe headache and a pupil involving third nerve palsy. It is an emergency. The patient has to be imaged to rule out a PCA aneurysm. Again, these syndromes associated with third cranial nerve palsy, these are all important for orals and multiple choice questions. Weber syndrome, where there's an ipsilateral third nerve with a contralateral hemiplegia because of the fascicular lesion. Benedict syndrome, because red nucleus area is involved, there is a contralateral hemitremor. North-Nagel syndrome, where the superior cerebellar peduncle is also involved, so there is a cerebellar ataxia along with the third nerve palsy. Claude syndrome, which is basically a combination of Benedict's and North-Nagel's, and Kenohan-North syndrome, where there is a compression at the free border of the stentorium cerebelli. So it causes the ipsilateral pupil to dilate, and there is a contralateral hemiplegia. There is also another question that is usually asked, like why does the pupil get involved in certain lesions, why the pupil is not involved in certain lesions? That is because of the difference in blood supply to the pupillary fibers. The pupillary fibers are peripheral, and they are supplied by the pial vessels, and the rest of the nerve is supplied by the vasa nervorum. So unless there is a compression of the nerve along with its blood supply, the pupillary fibers are not involved. So if there is a compression, even the pial vessels are also involved, so the pupil also gets involved in a third nerve palsy. Management is observation. If it is a microvascular lesion, we wait for the palsy to get better. In the intermediate time, we can prescribe prisms or patching. And if there is no improvement beyond 6 months, we can plan surgery. Surgery for a third nerve palsy is pretty difficult because of the multiple muscles that are involved. So there are various surgical options available. I think you can start looking in your textbook and read about it. The next is the trochlear nerve. So the trochlear nerve has a lot of differences compared to the other nerves. It is the most slender cranial nerve. It is the only nerve that arises from the dorsal surface of the brainstem, and there is a decussation of the nerve. And so it innervates the opposite superior oblique. Causes for it to get paralyzed include congenital, trauma, anterior medullary velum lesions, tumors, demyelination, diabetes, hypertension, and benign ICT, which is rare. So patients will present with an abnormal head posture, facial asymmetry, which is more common in a congenital trochlear nerve palsy, with a contralateral head tilt and certain depression. There is a hypertropia, and sometimes we may see a pseudotosis. There could be an inferior oblique overaction. We should also rule out bilateral superior oblique palsy.
Where I should see that.
So the 3-step test is the most important step for diagnosing a trochlear nerve palsy. This is something I really love, because this was taught to me by Dr. Amar. He made it like mathematics, which makes it so easy. When you start reading the book, you think, oh my God, it's such a difficult test. So imagine there is a patient with a right hypertropia, right over left hypertropia. If the right eye is going up, that means the depressors of the right eye are involved, or the elevators of the left eye are involved. So the depressors of the right eye are right inferior rectus and right superior oblique. As we know, the obliques act as depressors when the eye is adducted, and the recti act as depressors or elevators when the eye is abducted. So in this case, the right inferior rectus or the right superior oblique could be affected, or the left inferior oblique or left superior rectus could be affected. This is the first step. We know which eye is up or which eye is down. The second step is making the patient look to one side. So in the right gaze, if the right over left increases, the right eye is up and the left eye is down. So that means the right eye is going to be abducted. So that means the right inferior rectus could be involved, or since the left eye is adducted, the left inferior oblique could be involved. So now from 4 muscles, we are down to 2 muscles. So again, we have to bring it further down. So what we do, we make the patient tilt the head to one side. So if the patient is going to tilt to the right side, what will happen? The right eye should intort and the left eye should extort. Then only it will be stable. So as we know, the obliques, the superiors are the intorters. Sorry. Superiors are the intorters and the inferiors are the extorters. So in this case, when the patient has right over left increasing on right head tilt, the right eye should intort. Since we don't have any superiors here, so we go to the left eye and we'll see that the left eye is down. So the left inferior oblique would be involved in this case. And same way we should work out for the other side head tilt. And the same way we should work out when there is an increase in the right over left hypertropia in the next case. So this is basically like mathematics. When you start working out 2-3 times, it becomes like so easy for us when we see a patient with a hypertropia. So this is a child with a right over left hypertropia. As you can see, it looks like a pseudotosis in the left eye. So once the right eye is covered, the left eye is coming up to take up fixation. So now we know that the right eye is up and the left eye is down. So the second step of this test will be to see whether the hypertropia is increasing in right or left case. In the left case, we can see that the hypertropia is increasing, and in the right case, it's almost at the same level. So there is no increase. Again, it is increasing in the right head tilt. Patient is tilting the head to the right and it is increasing. Here, it is almost at the same level. So this is a case of superior oblique palsy, right superior oblique palsy, because of which there is an increase in the hypertropia to the opposite side and increase in the hypertropia when the head is tilted to the same side. There can be a bilateral superior oblique palsy where the patient can present with profound symptomatic or torsional diplopia. There is usually a less vertical deviation, chin depression, and there will be a right hypertropia in left case and left hypertropia in right case. Basically, the 3-step test will be positive on both sides. Except torsion will be more than 10 degrees. There is a large V esotropia. We have to differentiate between congenital and acquired cranial nerve palsy as well, because some patients have a congenital palsy, but they may present pretty late because they are not aware that they are having a palsy, because history will be very vague. Whereas in an acquired one, you do have a definite history of trauma. Patients usually don't complain of diplopia in a congenital one, only they have diplopia if it becomes decompensated, whereas acquired always have a diplopia. Facial asymmetry may be present in the congenital palsy. Head posture, again, patient is not aware, but when you start looking at photos, you may see. Whereas patient is aware of an abnormal head posture in an acquired palsy. High fusional amplitude will be present in a congenital one, and amblyopia may be present. Management, we have to wait for 6 months. If there is no improvement beyond 6 months, we can plan surgery depending on the amount of deviation and depending on whether unilateral or both sides superior oblique is affected. Next is the abducens nerve. This nerve is pretty important because it gives a false localizing sign when there is a paralysis of this nerve. So the nucleus of the nerve is in pons. Nucleus is near the horizontal gaze center, and facial nerve winds around the nucleus of the 6th nerve. It is also connected to it connects to the 3rd nerve via the MLF. Causes could be increased. Most common is that we see is increased intracranial hypertension, diabetes, tumors, aneurysms, trauma, caroticocavernous fistula, cavernous sinus thrombosis, inflammation, infiltration. How do we evaluate? Basically, we start looking out for ruling out all the causes. So you rule out history of headache, vomiting, fever, vaccination. Lyme disease can be a cause. Hemiparesis, plegia, diabetes, hypertension, face turn. Check for pupils, corneal sensation, because CT angle tumor can cause a decrease in corneal sensation. And fundus, it could be a disc edema, unilateral or bilateral. If it's associated with multiple sclerosis, there can be an optic neuritis along with a nerve palsy, or bilateral if it's an increased ICT. Proptosis could be present in a caroticocavernous fistula or a cavernous sinus thrombosis. Ear symptoms we have to look for to rule out Grad-Enigo syndrome. other cranial nerves involvement, and features of GCA, although very rare in India. Check for vision, color vision fields, diplopia charting, blood sugar, ESR, BP. MRI, we have to plan if there are other neurological deficits, if less than 50 years of age, no vasculopathic factors, and multiple cranial nerve palsies. Management, treat the cause, results, botulinum toxin, and surgery if there is no improvement beyond 6 months. What are the syndromes that could be associated with the sixth nerve? Again, Miller-Gubler syndrome, where 6-7 cranial nerve palsies with hemiparesis can be present. Raven syndrome with contralateral hemiparesis and sixth nerve only. Foveal syndrome, where 5, 6, 7, 8 can be affected with ipsilateral Horner's. Mobius syndrome, which I will be talking to you later. Grady-Nigo syndrome, where there is a lesion at the petrous apex. So it causes deafness, facial weakness, diplopia, and deep temporal headache. And at the Dorello's canal stretching can cause involvement of the other cranial nerves also with increased intracranial tension. CP angle. This is important because 5, 6, 7, 8 cranial nerves can be involved along with the cerebellar symptoms. The first symptom for a CP angle tumor is hearing loss, and the first sign is diminished corneal sensation. Always remember that. Next, we talk about cavernous sinus thrombosis. When multiple cranial nerves are involved, we have to localize where the lesion is. So 1, 2, 3 places where the cranial nerves are close together is, one is cavernous sinus, the other one is the orbital apex. So in cavernous sinus thrombosis, usually the infection happens from central facial infections, acute sinusitis, periorbital infections, most common in immunosuppressed. And here the motility limitations will be much more than proptosis compared to an orbital apex syndrome. Corneal sensation also will be reduced because trigeminal nerve first branch will be involved. If the thrombosis involves the posterior portion of the cavernous sinus, maxillary division also can be involved. Patient is systemically unwell, pupil is non-reactive, facial pain can be a presenting feature, and they can have aberrant regeneration. So in case of a cavernous sinus thrombosis, we have to plan a contrast enhanced CT, MRI, MRB, and blood counts, blood cultures, LP. Treatment is usually antimicrobial therapy, anticoagulation to prevent any further thrombosis. And it will be a prolonged treatment for these patients. And cavernous sinus thrombosis, I think with mucormycosis, a lot of patients have gone into having cavernous sinus thrombosis because of the infection from their sinuses. Next area where we have cranial nerves bunched together is the orbital apex, where there is a superior orbital fissure, inferior orbital fissure, and the optic canal within the tendinous ring of Zinn. Only when the superior orbital is involved, where there is a superior orbital fissuritis and inflammation in the superior orbital fissure, usually the patient has pain and proptosis, which is more compared to the limitation of motility. Since it is only the superior orbital fissure, optic nerve will not be involved. The first branch of the trigeminal nerve will be involved. Orbital apex syndrome, it is one of the most important questions that we get as a PG. In orbital apex syndrome, the difference from the superior orbital syndrome is the optic nerve is also involved. So 2, 3, 4, 6 and second branch of the fifth cranial nerve also can be involved. Proptosis will be present. There is a limitation of motility. Since the optic nerve is involved, RAPD and anisocoria will be there. Poor vision. There can be a disc edema or an optic disc atrophy with choroidal folds. Common causes include inflammation, which could be because of sarcoidosis, Tolosa-Hunt syndrome, SLE, vaginous granulomatosis, infective, traumatic, iatrogenic also, post-orbital or sinonasal surgeries, vascular reasons, tumor and mucosal. What is a Tolosa-Hunt syndrome? This is basically an inflammatory lesion happening in the orbital apex. So it causes painful limited eye movements due to some autoimmune response. It can happen in the orbital apex, very rarely in the cavernous sinus also. The common complaint will be a gnawing or a boring pain. That is what the patient says. It's a periorbital pain and multiple cranial nerve palsies. So again, we have to do a blood workup to rule out any microbiological infection. If everything else is ruled out, then start giving steroids. There is a very good response to steroids, but it could relapse rarely. Next is keratoconus fistula, again, where we can have multiple cranial nerve palsies. Patient presents with a pulsatile proptosis, chemosis, conjunctival congestion, and IOP increase due to episcleral venous pressure, and there is a limitation of motility, and on fundoscopy tortural vessels may be seen. We again come to the two more cranial nerves, which are not so important in terms of movement of the eye, but they are still important with respect to the eye. So the next one is the trigeminal nerve, which basically has sensory and motor nucleus. What we are bothered is more to do with the sensory part of the this cranial nerve. It again has a lot of parasympathetic fibers going to the pupil as well as to the lacrimal gland. So here, if the trigeminal nerve is affected, it can be part of multiple cranial nerve palsies. Sensory innervation to the face is affected. Most important is corneal reflex is diminished. So that is what gets us worried, and we have to make sure that we protect the cornea. What syndromes can be associated? Main thing is the Wallenberg syndrome, where the lesion is in the medulla. So there is loss of sensation along the ipsilateral fifth cranial nerve and contralateral sensory loss to the rest of the body. Trigeminal ganglion can have herpes infection, which can cause a trigeminal paralysis. Again, it can be part of cavernous sinus thrombosis and keratico-cavernous fistula. Facial nerve. Again, facial nerve is not important in terms of movement of the eye, but it is important in terms of protecting the cornea. So basically, applied anatomy wise, how it is important is how do you differentiate an upper motor neuron lesion and the lower motor neuron lesion. Since the upper half of face has a bilateral innervation of the facial nerve, an upper motor neuron lesion will always have a paralysis of the contralateral only lower half of the face, whereas a lower motor neuron lesion will have paralysis of the entire ipsilateral half of the face. So in upper motor neuron lesion, the upper half of face will be spared. So this is a video of a patient showing, you can see the lagophthalmos is present. The patient is not able to close the eye completely. There is a deviation in the angle of the mouth, and the nasolabial fold on the left side is absent. And there is an esotropia also in this patient. On cover test, it is very much visible. I'll just, as you can see here, there is an abduction deficit in this patient. So this patient had a 7th and a 6th cranial nerve palsy. What are the syndromes that can be associated? Miller-Gubler syndrome, which we saw some time back, foveal syndrome, Mobius syndrome. Mobius syndrome is basically a congenital facial nerve palsy with the hypoplasia of the motor nucleus. Patient can have lagophthalmos, crocodile tear phenomenon, reduced tearing. It then can be associated with a 6th nerve palsy also and a horizontal gaze palsy. Bell's palsy, which is a low motor neuron lesion of the facial nerve, which is unilateral and acute. Ramsay-Hunt syndrome, which is part of the infection due to herpes zoster at the geniculate ganglion. And another one is a Melkerson-Rosenthal syndrome. Treatment is protect the cornea. That is the most important thing, protect the cornea. Steroids for idiopathic palsy and exercises, and antiviral drugs if it is caused by virus. I think I've covered as much as I can in the 15 minutes given to me. A special thanks to Dr. Saundri for sharing her few videos with me. And thank you, team, for giving me this opportunity. Happy Deepavali to all of you.
Thank you very much, ma'am. As you said, it's a lot to cover in 15 minutes, but you managed to make it concise yet thorough at the same time. Thanks a lot. Our final speaker for today is Dr. Preeti Naveen. She's the academic director for our PG and fellowship programs and a senior consultant in the cornea and refractive surgery department. She'll be talking about single pass 4-through pupilloplasty today.
Are you able to see my presentation, Vaishnavi?
Yes, ma'am, we're able to.
So in the interest of time, I'll try to finish fast. So we're going to be talking about a single pass 4-throw pupilloplasty technique. So when we talk about pupilloplasty, the first published pupilloplasty technique was made by McKenna in 1976 when he tried to repair an iris defect after an ICC. So there have been multiple techniques followed, and we are going to be discussing only about the single pass 4-through pupilloplasty. So when you look at iris reconstruction techniques, you have surgical and non-surgical modalities. And the surgical would be your Seepser sliding knot technique. Then you have your pupil cerclage technique, SFT, which is also known as a single pass 4-through pupilloplasty, your pinhole pupilloplasty, which is an advanced version of an SFT where you try to reduce the size of the pupil with regards to keeping a pinhole in front of it and finding out which exactly suits the patient's requirement. And then you have your mechanal suture and your non-surgical treatment options. So I'm not going to go in detail about this. So let's talk only about SFT. So the principle behind a single pass 4-through pupilloplasty is that we use a polypropylene suture. It could be either a 9-O-proline or a 10-O-proline suture. And I would be showing you some video to explain this. But the principle is you're trying to create a helical configuration by intertwining the loop in a self-locking manner to prevent it from opening up inside the eye. And why do we do this pupil reconstruction? Mainly for people who complain of photophobia and glare, and people with traumatic mydriasis, and we're trying to improve their quality of life. And indications for a corneal surgeon, it would be prior to an endothelial keratoplasty, where we inject grafts into the patient's eye, and especially in an aphakic eye or with a poor iris constitution, we would prefer the anterior segment to be made normal before we try to inject the graft because of the fear of the graft getting displaced into the posterior segment. And also you need an adequate anterior chamber to unroll your graft. Glaucoma related indications would be an angle closure glaucoma, where you could try to bring in the pupil and try to open up the angles. Then you have plateau iris syndrome and a broad peripheral anterior synechiae. Pupil related would be traumatic mydriasis, uretzavalia, which is pretty common after a DALC surgery, and you have iatrogenic iridectomies and also congenital iris defects. And IOP related issues, again, if there is an optic capture, or in cases of a glued IOL, post-glued IOL, if you feel there is an optic capture there, and also for the purpose of prevention of a posterior synechiae developing. Your relative contraindications would be any phakic eye. With a clear lens, we wouldn't want to damage a clear lens, and in case of an atrophic iris. So I'll just play a video and we'll walk through the entire procedure. So pinhole pupilloplasty, like I told you, it's basically SFT being done multiple times and to reduce the size of the pupil. And the purpose of it is in patients with a high astigmatism. We feel that a pinhole pupilloplasty really benefits them in reducing their aberrations. And the depth of focus also increases in these patients, and they have this wow effect immediately after surgery. Are you able to see my video, Vaishnavi?
No, ma'am, not yet.
No.
Madam, please select the share screen, bro.
Yeah. Can you see it now?
Yes.
Okay. So this is a video of just a sec. Okay, so this is a video of a glued IOL there with you have an inferior. And one thing you'll have to keep in mind is before you do any intraocular procedure, you have to have some kind of an infusion in the eye. If you don't have that, at least a visco-filled eye should be there before you do this. So we have a trocar there for a continuous infusion. So it's an animated and video. So if you see the proximal iris is being, and you have a proximal and a distal iris, the video is pretty self-explanatory. So you have a stab incision being made at the distal end. And so you use an MST forceps to help you pull the iris tissue before you pass in your needle. So one thing you'll have to keep in mind is before you pass the needle, just make sure you don't go too close to the rim over here, because of the traction, when you try to pull it out, the iris can rip apart. So try to go a little behind the rim of the iris tissue just to make sure you're successful in your first attempt. So that would be your proximal incision as shown in the animation video, and your proximal iris. Then you go with your distal iris. So this is typically a 26 gauge needle. And one more point to be kept in mind is while you're going with a 26 needle, you'll have to make sure that you go directly through the side port incision and make side to side movement so that you don't have any corneal tissue stuck in your pars, which will again hinder your process of getting a proper pupilloplasty. So once you catch hold of this, you railroad the proline suture into the 26 gauge needle to try to extract it from the distal incision which you've made. So once you've done this, you'll just have to pull out a loop. So now you have 4 parts of the suture, which is inside the patient's eye. And you will have to pull out the proximal part. This part is what you will have to pull out as a loop, and which comes out through your distal incision. So it is a pretty easy surgery compared to all the other pupil reconstruction procedures. Very simple. The learning curve is very, very less compared to all the other procedures. And so when you pull out a loop, you will have to again make 4 throws. That is why it's called as a single pass and a 4 throw pupilloplasty. If in case you have doubt, you have missed or you have lost track of your count, maybe an extra throw is not going to, it will help you. So we pull the knot together, and that is your helical knot being formed, in which you're bringing both the proximal and the distal iris parts together. So the same procedure can be repeated multiple times in order to get a proper pupil configuration of your choice. And so that is your helical knot video. I will also show you another video where a pinhole pupilloplasty is being done, which is a similar technique. And we had done it in a patient with and so then you cut off the knots there. Be careful while you're doing that, you don't want to open up your pupilloplasty knot. Just give me a minute. I'll just play another video for you and we'll be done with that. So we do have an epsilon instrument which has pupil diameters of different sizes, which we keep on a patient pre-op to assess the proper pupil size which would suit them. So I'm going to show you a video of a post-RK patient who was referred to us. Are you able to, 1 second.
Not yet. I think you have to share. Yeah, yes.
You able to see it now?
Yes, yes, yes.
Okay. So this is a patient of a post-RK and who was referred to us for a cataract surgery, and we decided to do a pupilloplasty also on him. I'm going to skip the part of the cataract surgery. And so RK surgeries you'll have to keep in mind because you can always have these radial incisions opening up. So you'll just have to make sure you take care of that during your cataract surgery. And this is a pupilloplasty being done for this patient. And these patients, we check their aberrations on a pentacam pre-op, and post-op is done just to see how beneficial the procedure has been. And they do have, like I told you, there is a wow factor post-surgery because all the aberrations are negated by this procedure. So that is pupilloplasty being done on either side. So whenever you do a pupilloplasty technique, just be careful to handle the iris tissue very gently because you don't want excessive bleeding or you don't want a tear of the iris tissue, and also you don't want to induce an iridodialysis in these cases. So that is a 4-throw pupilloplasty which is being done. And here you have an infusion cannula in the anterior chamber. The previous case, you had it in the posterior chamber. So it varies case to case based on the situation there. So you'll have to look at your Purkinje image in these cases when you're trying to especially do a pinhole pupilloplasty. So it has to be centered around that area. So until you get that, I think you should try and get it exactly correct. So that is a pinhole pupillary marker which we have. It's around a 1.5 mm, which we found was suitable for this patient prior to surgery. And so once you're done with the pupilloplasty, you have to make sure that the Purkinje images exactly coincide with your marker. And once that is done, you can, that's probably the end of the surgery. And you remove the marker. So that's in a gist about pupilloplasty. I'm sorry we're not able to talk about the other techniques here. And thank you so much for the opportunity and thanks for the patient hearing.
Thank you very much, ma'am. So I think that brings us to the end of this week's session. We'll close for now. Wish you all a very, very happy Deepavali. Stay safe and see you next week for our final session for this year at the same time. Thanks for your attention, everyone.